know you until you have a conversation. They're not going to trust you just because you're in a set of scrubs and you walked in their room. That's kind of a false sense of entitlement, right? They don't have any reason to trust you. So as you go into the weekend, I want you to start thinking about some scenarios. How would you respond to this patient? How would you respond to somebody that has lost 3 pounds and is wondering, what does that mean? How would you respond to that? How are you going to respond to somebody who's a new admission in a long-term care setting and had to sell their car and their home and their possessions and give away their pet, and they have no family visiting and they feel like they were simply dumped and forgotten? They're probably going to be a little depressed, withdrawn, reticent, not really wanting to engage with other people, not wanting to get involved in activities. Their appetite might be affected, and they may not want to be bothered with you doing the skills. They may withdraw. How are you going to communicate with those individuals? Now, again, your communication strategy is going to depend in a large part on your experience. If you're younger, you're probably more likely to kind of back away and, I'll let them work it out and I'll come back later. If you're older, you might be able to relate to some of the things that they're feeling and exhibiting, and you might be able to get them to talk a little bit about it, or at least ask, do you want to talk about it? So your experience is going to affect how you approach this. But here's the problem. Whichever direction you decide, either back away and let them work it out, or try to get them to talk about it, talk it through. Whichever one of those pathways you take is going to set up their response for all of your future encounters with that patient. So if you back away and just let them kind of work it out themselves, they may not trust you because you're not responsive to their needs. They're pouting and you're not paying attention. If you try to get them to talk about it, they may come away with a feeling that at least somebody cares. Even if I haven't worked out what I want to say or how I feel and I don't want to talk about it right now, at least somebody showed some interest in me in this strange place. Now, the only types of questions that you might get on the state exam, it's not going to ask you, how would you respond to this? Because remember, that's going to be based on your experience level. But you might have a question about communication that basically is trying to get you to ask the patient to talk about it, to try to get more out of them about how they're feeling. If you see that as the answer, that is the right answer. Offering to listen while somebody talks is always a good method of communication. Now, younger people may not intuitively know this. Older people may directly run to that. So, but there's a problem with the older people that I didn't talk about, older caregivers. And you guys are going to fall into this at some point. Some of you are younger now. It doesn't apply. But at some point, this will apply to you. I hate to use the word mistake, but that's really the only word coming to mind here, that older people have when they're relating to patients. And by older, I mean in your 30s and 40s, when you have some communication experience under you, is you're trying to form a connection. Okay. So you go from stranger danger to trying to form a connection. And one of the ways that we do that in healthcare that is absolutely wrong, completely off base, do not do this, is to try to relate to your patient's condition using some experience that you've already had. So your patient may say, oh my gosh, I don't know what I'm going to do. I'm 92 years old. The doctor just told me I have cancer. I don't know whether to go through chemo and radiation. How is that going to affect my quality of life? I'm super stressed out about this. I don't even know if I have the money to do this. What am I going to do? And they may be talking this out. Now, your initial reaction is to form a connection there, right? You want to help them. You want to support. You want to form that connection. So you end up saying something like, oh yeah, we've had lots of patients with that condition and they did this. Or, oh yeah, my mom had that type of cancer and it didn't matter what she did, she died in 3 months. You're drawing off of your experience to form a connection with what the patient is dealing with. Your experience has absolutely nothing to do with what this patient is dealing with. Nothing. Because every patient is an individual, and that's what we learn on day one. So it all goes back to that individuality of the patient. So just like every care plan is different, every condition is going to exhibit different outcomes in different patients. Nobody follows the exact same trajectory. So every age range is going to have their own challenges with communication. Does that make sense? You have to be aware of this because you are going to have to communicate with your patients. If you don't, they're simply not going to trust you. So this is where it gets kind of hard. You've got to practice. There's no way around that. You have to practice. And you're either going to practice in real life and learn. Usually, you learn what not to do by doing that and then having bad consequences. Or you can practice these hard scenarios by communicating with family members and role playing it. But you need experience communicating one way or another. Does that make sense? Okay. Now, I say all of that to lead you to this. Does anybody have any questions on what I went over so far? Communication is something we can't teach you. It has to be experienced. Okay. All right. Now, go ahead.
I'm going to wait till you.
No, go ahead.
Because you're probably going to say it. What about the people that the patient ends up talking to you for too long or whatever? Like, I've been bartending my whole life, so to cut you know what I mean? That's a whole different setting to cut somebody off and walk away. And I know that we're limited on time. Very limited.
Right.
So
again, experience is your best teacher here. And every situation is going to be different. I can't give you one size fits all solution to that. However, when we're doing the skills, as we're doing hand care, as we're doing foot care, as we're feeding a patient, as we're changing the occupied bed, we have minutes there that we can have a meaningful conversation in. So instead of, this is where practice comes in. You want to be so good at these skills that you don't even think about them while you're doing them. It's like driving. Have you ever driven somewhere and realized that once you got there that you really didn't think about the drive itself, right? You're operating a 2-ton killing machine on wheels, but your brain wasn't engaged. That's a little scary. But if you do something often enough, your brain doesn't have to be engaged. It just kind of picks up if there's something that needs its attention. Everything else goes on autopilot. When you practice these skills, that's exactly what will happen. And now while I'm doing foot care, I don't have to think about, okay, whatever I wash, I rinse. Whatever I rinse, I dry. It's automatic. You're on autopilot. You know what to do. And now that opens that time up to have these conversations. Does that make sense? So during your skills. Okay, so we have all of that communication stuff. Here's where it really gets tricky. Now, I told you guys that your communication attempts as caregivers are going to be dependent on your own experience, right? So you have to adapt as you learn. What makes this really tricky is your communication with the patients has to change based on them. If you have a 92-year-old with cancer diagnosis who's trying to work through what that means to them, that is going to require a different communication attempt than a 29-year-old with a cancer diagnosis that is trying to work through all of that. Think about how you would respond to each one of those. What would be the same and what would be different? Oh, thank you.
Yeah.
Here, I'll get that. I'll get
Well,
this one.
actually, she can just take that one, then I'll give her this one.
Okay. Let me see that chair real quick. Can I see your chair?
Yeah, here you go. Here you go.
I saw your chair. All right. So let's think about how we would communicate with those two people a little bit differently. We have somebody at 92 years old toward the end of their life. They're in a long-term care scenario. They're trying to make decisions based on, their finances, their quality of life, all of that. And then we have a 29-year-old who just got a cancer diagnosis. They're both probably going to be pretty depressed, right? But one is at the end of their life, one is at the beginning of their life. Is this the same situation? Not really. So your communication is going to have to change a little bit there as well. This is where communication gets really, really hard. Do not assume that every single patient that you care for as a CNA is going to be old. They're not. There are 21-year-olds right now in nursing homes because they had a catastrophic illness or injury and their family has to work and cannot take care of them at home. In a hospital setting, you will have babies to 110 and everything in between. So we have to understand that communication is a very complex, multi-layered subject. It's not something I'm going to spend a lot of time on in class, but it is going to impact your ability to do the skills, quite frankly, because your patients are not going to trust you until they trust you. It's not automatic. Good. Especially in today's environment. People are very divisive right now. And because of that, there's just a lack of trust kind of universally. You're going to have to break through that. Okay. Does that make sense? All right. One more current event. This one is a little gruesome. Hopefully you digested your breakfast already. So there was a nurse. Now I'm going to talk about this. This was a nurse that did this, not a CNA, but this very well could have been a CNA. There was a patient in a long-term care setting who had a wound on their ankle that literally ate through the muscle, the tendon, the tissue, the bone. And it was just hanging off by a small piece of tendon, right? So it was a partial amputation, and it's just, and a surgical consult had been requested. And the nurse, for some reason, I do not understand her reasoning. I don't think there is any understanding of her reasoning. But somehow she found that whole situation offensive and decided to take matters into her own hands and amputated the patient's foot by cutting off what was left. Now, this is horrifying, absolutely horrifying. And the nurse is now having her, she was terminated. She's going in front of the board. This is definitely operating outside of her scope of practice. But I bring this up because this is something that a CNA might consider doing. I mean, the foot is just dangling there. It's not doing anything. It's not attached anymore. I can't do my job. I can't turn the patient over and change a sheet with this foot just kind of dangling there. Let me just take care of that. And, this might be something that a CNA can rationalize pretty easily. Please don't. This is not on the care plan. This action was not on the care plan. Should it have been done? So when I say the care plan, the whole care plan, and nothing but the care plan, these are the situations I'm referring to. I've got a million others, but this is just one that happened to be in the news this week. Here's another one. Some of you are probably interested in working in non-traditional roles. Like somebody might be interested in working in the ER because you're high energy. Somebody might be interested in working in the ICU because you like the technical stuff. Some of you might be interested in working in the mother-baby unit where you can work with little tiny babies, and isn't that wonderful? So here's an example of why CNAs are not always used in these non-traditional settings. Now, I want to bring your attention to, remember our role, right? CNAs do normal. Normal are routine tasks on stable patients that you've been trained to do, right? But the problem is that sometimes these situations creep up that we weren't expecting, okay? And how do you respond to that? Now, in a non-traditional setting, these unexpected things are going to be much more common. This is why CNAs are rarely working in non-traditional roles. Doesn't mean that they can't or that there won't be any openings, but I'm telling you that non-traditional roles have a higher risk level for you to step outside of your scope of practice without even thinking about it. So here's one. Again, this was nurses, but this is, again, it could have been a CNA very easily. Mother-baby unit, nurse coming on shift, takes report from the offgoing nurse and goes in and checks on the patients. And there's 2 patients that are breastfeeding their babies, brand new babies, mamas are breastfeeding. Nurse goes in, checks on them, everything is fine. Later in the shift, she checks ID bands. And it turns out that the babies had been accidentally given to the wrong mamas. Now, both of these women had breastfed babies that weren't theirs. That's a big deal because it's a body fluid. Breast milk is a body fluid, and pathogens, as we know, can transfer in body fluids. So now there's got to be lab work done for both mamas to make sure that there was nothing that could have passed on to babies. There was a lot of corporate talking about the situation. But here's what was interesting. The nurse that discovered it reported it. Hey, babies went to the wrong mamas. We need to know, we need some processes in place to prevent this from happening again. Thankfully, I mean, they caught it pretty quick. Babies were switched back. Everybody took home the right baby. Everything was fine. But this nurse did not follow policy and procedure. Policy and procedure was when you first come on shift, you check both mama's bracelet and baby's bracelet to verify that mama has the right baby. Now, I want you to think about this for a second, right? To us, that's a very common sense policy and procedure. Should be done, no big deal. But let's say that you've worked in the same position for 5 years And every beginning of the shift, you check mama's bracelet and baby's bracelet. They always match. Mama's bracelet, baby's bracelet. They always match. Mama's bracelet, baby's bracelet. They always match. Mama's, and so on. Do you think you might get compliant or complacent and not really pay attention anymore, or not really prioritize that? Or maybe just skip it altogether because in 5 years, nobody's ever made this mistake. So because she did not follow the policy and procedure, she was terminated. She was not the one that mixed up the babies. That person is still working. That person made an error. But the person that did not follow the policy and procedure is the one that got terminated. You need to understand how important these policies and procedures are. We talked about it on class 1. And I asked you guys, how many of you were working? How many of you have actually looked at the policy and procedure manual where you're working? Very few people do. But if you violate anything in that policy and procedure manual, you are the one that's going to lose your job. Ignorance is no excuse. Now, this absolutely could have been a CNA in that scenario. Absolutely. And it seems very routine. You make sure the right baby goes to the right mama. I mean, that's just kind of a no-brainer, right? It's very routine. But when you do a routine action over and over and over and over and over again, it becomes kind of superfluous. I don't care if I do it because it's never wrong. And then things get missed. Now, because of the importance of this, we don't normally have CNAs in mother-baby units. Does that make sense? If nurses can mess this up, a CNA absolutely could mess this up. Good. So I want you to keep that in mind as you're looking for positions, because next week we're going to talk about finding a job. And some of you are starting to think about what area you want to work in. And if you're thinking about non-traditional settings, I want you to remember that it's not a discrimination against you as a CNA. It's that the tasks that have to be performed, there's a high margin of error and the stakes are high. Does that make sense? Okay. Jake, are we
You're still live.
Are we good?
Yes, ma'am. You have audio.
I have audio?
Mhm.
Can I have my mic back?
Could not get it to work.
Oh, okay. All right. So
you've been functioning off of the iPhone microphone
Okay.
this whole time.
Good.
I had to take down the screen and put in a new one because unfortunately it wouldn't let me to re-enter the original one.
Okay, that's fine. Thank you very much. All right, guys. So all of that being said, we've talked about communication, which is pretty important. So when it comes to being a CNA, it's not just about learning how to take a pulse or how to do range of motion or how to give Peri-Care. There's so much more to it. You have to know how your facility wants these tasks done. You have to know how to communicate with the patient while you're doing the tasks. You have to know what to report. Basically, if you know it, who should know it? The nurse. So there's a lot of little components to this beyond how to take a pulse. Does that make sense? So during the test, one of the things that comes up quite a bit is if I have to start over or if I have to make a correction, who should I talk to? And the answer is the patient, always, because you're demonstrating to the nurse, the evaluator who is there, that you understand communication with the patient. Okay, good. Okay. All right, so we're going to do a quick review. As a CNA, we follow the care plan, the whole care plan, and nothing but the care plan. We observe for any abnormalities, changes, pain, Anything that we notice that stands out to us, we're going to report to the nurse. Remember, if you know it, the nurse should know it. So any answer on the state exam that says report to the nurse is probably the right answer, with one exception. If it's an emergency, if your patient's life is literally on the line, they're having a heart, or their heart has stopped and you need to do CPR, they're choking and not breathing and you need to do the Heimlich maneuver, they are on fire and you need to put the flames out. If their life is currently in mortal jeopardy, action first. Do CPR, start CPR, do the Heimlich maneuver or abdominal thrusts, put the fire out, okay, on the patient. Does that make sense? Okay. Mortal jeopardy requires action. Can you imagine a patient standing there choking, can't breathe, right? And you're like, hold on, I'll be right back. I'm going to go get the nurse. Is that patient going to live? Probably not. Okay. So action first if it's mortal jeopardy. If it's not mortal jeopardy, notify the nurse. Good. Okay. So this should help you answer probably about half of the questions on the test. Following the care plan, making observations, knowing how to handle emergencies, and knowing how to communicate. Right? That's quite a bit of the written test. How many guys have downloaded the ebook, the free ebook? Anybody?
I tried.
Yeah, wasn't sure.
Okay, if you go to there's on your the sheet I gave you the first day, there's a little QR code. You can scan it, or you can go to 4YourCNA.com/ebook and fill out the little contact form. It'll send it to your email, and then you just download it to your device, and it lives on your device. So go to your downloads folder to find it.
That's probably what
Yeah.
I did fill the little box. Okay.
Okay. Yeah. It when you download it, it goes to your downloads folder wherever on your device, whether it's computer or phone or whatever. So find your downloads folder and it'll be in there. Okay. All right. Thank you, Jake. All right. So once we know what to do, we have to do it. So every skill is going to start with the opening, and every opening starts with a knock. Once you enter, you're going to greet the resident, address them by name, and then introduce yourself by name and title. You'll describe what we're there to do and then get permission. Once you do that, you can close the curtain, wash your hands, get your supplies, and we're ready to start the skill. Don't get your supplies first and then walk in the patient's room. If you watch YouTube videos out there, a lot of the demonstrations you see do just that. They go get their supplies and then they enter the patient's room. You're not touching those supplies with clean hands. And that's a graded checkpoint. So be careful about the resources that you're using to study with. I'm not saying that mine are the only ones. That's not what I'm saying. But on my videos, I actually show you the checkpoints that are associated with the action so you can make sure you're keeping me honest. Okay. Just be careful there. I actually had a student a couple classes ago that was watching some other videos and failed the skill and then came back to me and said, well, why did I fail? Because, these people said to do this. Just be careful, because unless they are showing you proof that that's the right, bless you, that is the right action, it could get you in trouble. All right. So one of the supplies we have to consider is gloves. We're going to wear gloves if we're going to touch body fluids, personal skin, or non-intact skin. We don't wear gloves for everything. Bless you. We don't wear gloves for everything, because when you do, you stop paying attention to what you're touching with those gloves. It's funny. I went to a local grocery store. Bless you. And I went to like their hot food service area, and I was going to get just a couple of chicken, like popcorn chicken, you know, to snack on because I hadn't had lunch. And the woman, I'd asked her, and she says, let me go in the back and just check, because she didn't have any in the hot case thing. So she goes into the freezer and pulls out this big box of these popcorn chicken, right? And she's like, it'll take about 12 minutes to get them ready for you. And I was like, no, I really don't have that kind of time. I'll just take this instead. And I pointed to these potato puffs, which are really good, by the way. And so she says, okay, let me go put this back in the freezer then before I get those for you. So she goes and puts the box in the freezer and comes back out, right? And all I can think of this whole time is my pictures. So she opens up the hot case, and she goes to reach in, and she looks at her hand, which has gloves on, and she pulls her hand back out, and she says, let me change my gloves first. I was like, thank you. That's awesome. Have you watched my video on this? Because it was the same place that I had done the other pictures at. So I found that was very interesting. This just happened Monday afternoon, actually. So I thought that was very interesting. She went to reach in, she looked at her hand, saw the glove, thought about all the things those gloves had touched, and said, let me change my gloves. So I thought that was neat.
You probably could have stepped smiling.
So I was just happy that somebody was kind of thinking through that, right? I would have eaten the potato puffs anyway, because my immune system needs to work out. That's fine. But the fact that there was some awareness there was good. So we don't wear gloves for everything. We have to know when to wear them. But if we do decide to wear them, we are going to make sure the first thing those clean gloves touch is the patient, not the toothpaste, not the towel, not the bedpan. You want to make sure the first thing the gloves touch is the patient. That way, we're making sure we're keeping those gloves clean for our patient. Once you've touched the patient, your gloves are now not clean. So pay attention to what you're touching in the environment, particularly the sheet. This is the part that I'm concerned about, right? If we're going to pull this sheet up next to your patient's face, and you're touching here to pull this sheet up next to the patient's face, on that face are all kinds of portals of entry. If you've got pathogens on your hands, you don't want to bring them right up next to all your patients' doorways. So make sure that you're not touching the sheet with soiled gloves, body fluid gloves. Now, once you've worn those gloves, you got to take them off correctly. You're going to pinch up at the base of the palm and then go under to remove. If we're going to use supplies, we need a place to put them. And that's where a barrier is going to come in. It gives us a clean place to put our clean supplies. We only touch supplies with clean hands. Go get the barrier first, put it on the table, and then go back and get the rest of your supplies. While you're carrying those supplies, don't let them touch your uniform. Don't hold them against you. One of the supplies you might need is a privacy blanket. Privacy blankets are used anytime our patient is uncovered or undressed, and we use them to keep our patient warm and provide privacy. The curtain alone is not enough. If you're going to put a privacy blanket on, don't snap it, don't shake it, lay it out over the sheet, and then pull that sheet down underneath. That way your patient's never exposed. I want to see their knobby knees. And then if you're using a privacy blanket, remove your gloves first before you take the blanket off. Linen rules. Anytime we use linens are sheets, clothing, towels, washcloths, privacy blanket, basically anything up here is a linen. You don't want them to touch your uniform because your uniform is not clean once you've started working. You have to have clean hands to get your linens. Don't snap or shake them, and don't let anything touch the floor. Whether it's clean or dirty, it doesn't touch the floor. Clean rolls toward me dirty rolls away. And we use that anytime we're putting something under the patient. And then anything that you take and don't use gets put in dirty linen. Don't leave it for later. We learned scoot and roll. Patient always has to be in the middle of the bed. You're always going to pull the patient toward you and then turn them away from you. That way you're behind, they're behind. And when you turn the patient after the turn, they have to be in the middle of the bed. If you turn a patient and they look like they're too close to the edge, don't ignore it. Bring them back to their backs, get them further towards you, and then turn them on their side. Remember, the patient must be in the middle of the bed at all times. You're not going to have side rails to keep them safe. Washing rules. This is pretty easy. Whatever you wash, you rinse. Whatever you rinse, you dry. Don't put soap in the basin because you need rinsing water. You're going to use a paper towel to turn the faucet on. You check it. The patient checks it. Should be warm, not hot or cold. If the water gets too cold or soapy while you're doing your skill, change the water. Try not to get your surface wet. If you're working on the bed, put something under where you're washing, like a towel. If you're working on the floor, put a barrier down. If you're working on the table, put a barrier down. Barriers are waterproof and absorbent. Okay. Make sense? Okay. If you're going to use lotion, warm it up first, wipe off the excess. And then we had to learn how to clean our basins. Basins are all cleaned the same way. Rinse it, dry it, store it. That's all you got to do for the test. Rinse, dry, store. If you do have to disinfect, this process allows for disinfection. And then we learned shoe rules. This was the very last principle that we learned. Slipper socks are not enough. If the patient's feet hit the floor, we got to talk about the shoes. If you're going to put a gait belt on, you put it over the clothing around the waist and check it with 4 fingers to make sure that it's snug enough. You ask your patient to put their hands on your shoulders, make sure their feet are flat on the floor, and then you count to 3 before lifting. Before you help them sit down, make sure they can feel the chair behind them. And you want to use those proper body mechanics. Don't stand directly in front of the patient. All skills end with a closing. This is the end of every single skill that we do. We ensure a clean environment, make sure the patient is safe in bed. The bed is in the low position. You want to make sure that you're asking about comfort. They want to hear that word. Are you comfortable? And comfort is also about preferences, right? So offer a magazine, TV remote, something like that. Just ask what they prefer. Open the privacy curtain, give them their call light. Once all of that is done, you're going to go clean your hands. If you have to document, you would do so then, and then clean your hands again, because our cardinal rule here is end skill with clean hands. Good? All right, taking a pulse. This is the amount of times a heart beats over 1 minute. Normal is between 60 and 100. What finger can you not use to take a pulse with? Your thumb. So you're going to use 2 fingers at the top of the wrist. Find the pulse, put your thumb on the back, pick a starting point on the clock, and you're going to count as long as the care plan tells you to. If the care plan doesn't specify, it's 15 seconds and multiply by 4. But our care plan for the test says 1 full minute. So make sure you're counting for that 1 full minute. This is a documentation skill, so you have to write it down. We learned how to dress a resident with a weak arm. For the test, you're just putting on socks, pants, shirt, doesn't matter what order, but when you get to the shirt, it's USA first. Undress, strong arm first. Dress, weak arm first. Try to minimize exposure using a privacy blanket. Make sure that you get all of your clothing before you undress the patient, and everything is fastened and appears neat at the end of the skill. We learned how to do hand and nail care. You soak the hand, you wash the hand, you rinse the hand, you dry the hand. You Clean under the edges with an orange stick and file the rough edges with an emery board, and then apply lotion last. Wipe that lotion off. Making an occupied bed, you're going to change the sheets with the patient remaining in the bed. So we change the bottom sheet a half at a time. So you'll loosen the corners. Clean rolls toward me, dirty rolls away. So roll the dirty sheet toward the patient, tuck it under them, put the clean sheet on the bed, roll it toward us, tuck it under the dirty, have the patient roll back on their back in the middle of the bed, go around to the other side, do the same thing. Minimize wrinkles from under the patient, put the top sheet on, secure the end of the sheet under the mattress, and then change that pillowcase. Limit the amount of time they're without the pillow. We learned how to change a patient's position. So if we want to roll somebody over onto their side and they cannot roll themselves, you're going to position them to make the roll easier. Scoot them all towards you, and then furthest arm up, closest arm crosses the chest, closest knee bent, furthest knee angled. Hand on the hip and the shoulder, and roll them onto their side. It does not take a lot of force. Use a pillow behind their back and a roll to keep them there. One under that top arm, one in between the legs, and adjust the one under the head. Call light goes in the bottom hand. We learned how to do foot care. This hand and nail care a little lower, nothing with the toenails. So we soak the foot, we wash the foot, we rinse the foot, we dry the foot. We apply lotion to the foot, but the real reason we're there is to look at the foot. Don't put the foot directly on the bare floor. Make sure you have a barrier there. Mouth care. It's brushing teeth. Make sure the patient's sitting fully upright. Protect their clothing with a towel. Wet the toothbrush before you brush their teeth. Put a little bit of toothpaste on it and brush whatever they got. Let them rinse and spit. Leave their mouth area dry. And make sure you've cleaned your environment at the end. This does require gloves. Respirations. This is breathing. It's the amount of times the patient breathes over 1 full minute. So you can count for 15 seconds and multiply by 4, just like we did pulse, but our care plan for this says 1 full minute, so we'll count for that. Normal is between 12 and 20. In and out counts as 1. Don't tell the patient you're counting their respirations. Range of motion. We've learned one. We're going to learn another one today. You follow the care plan. So what body part, what exercises, how many repetitions are we doing? Follow that. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. Ask about pain and discomfort. Denture care, just like mouth care, with an extra step. We're going to use a washcloth in the bottom of the sink so our dentures don't break if we drop them. We're going to keep them over the sink. Don't carry them around. They are going to be stored in a cup of cool, clean water at the end with a paper towel underneath just to catch any water drips. And then you're going to do mouth care using a toothette. Ambulate with a gait belt. You guys starting to see how much you've learned? It's a lot. Ambulate with a gait belt. You're going to walk the patient as far as care plan says. Remember, that's round trip. They're probably going to give you a destination to go to. If there's any obstacles in your way, move them first. Put the gait belt around the patient, count to 3, help them stand, make sure that they're not dizzy or weak, and then you'll let them lead. Pay attention to the patient as you do this. Turn them around, bring them back to the chair, and you're going to help lower them using that whole shoe rules, body mechanics thing we talked about. Okay. And then partial bed bath. This was another washing skill. Whatever we wash, we rinse. Whatever we rinse, we dry. Our care plan is basically telling us face to waist, front and back, one arm and hand. We're going to start with the face first, no soap. And then we're going to wash everything the care plan told us to, rinse it, dry it, leave the patient in a clean gown. They don't care when you do the gown thing. And we're going to give a back rub with a little bit of lotion. So lotion, warm it up, little back rub, wipe off the excess. Good. It's a lot of information. So today we have 4 skills to learn. None of them are very hard, but it is going to take me a little bit of time to teach them because I have a lot to say. So the first thing we're going to learn is transferring from bed to wheelchair. And this has a lot of ambulation in it as far as the steps that we learned for ambulation. Remember that before we ambulated the patient, we had to make sure they had shoes on. Right? Patient's feet hit the floor. We got to talk about their shoes. We put the gait belt on. We had the patient put their hands on our shoulders, and we lifted using the gait belt at the sides or the back. All of that is exactly the same. But instead of standing the patient up to go for a walk, we're going to stand them up, turn them, and sit them down in that wheelchair. So what we have to learn for this skill is about the wheelchair itself. Okay. It's a new piece of equipment we're going to learn about. The skill we're going to do after this is feeding a resident. I've got a whole lecture on food intake and estimating percentages that we have to go through. And Peri-Care is just like partial bed bath. We're going to use that same leaves method. Oops. And it's a washing skill. So whatever we wash, we rinse. Whatever we rinse, we dry. So there's not a whole lot to teach you with that, except that we have to learn about incontinence. What is incontinence? What are the infection risks here? What do I need to know to do this skill to keep my patients safe? So we're going to focus on those topics. And then I'm going to show you one more range of motion because we had to pull those range of motions to this class period. All right. So everybody good with that? Okay. In your book, turn to page 72. Jake, can you, oh, no. Thank you for working on that, Jake. I appreciate it.
Sorry, I couldn't get it corrected.
Oh, it's okay. All right. So when you're looking at page 72 in your book, you've got the principles down the side. They're all spelled out for us here. There's nothing to learn. We know this. We know how to follow the care plan. We know to do our opening. We know to evaluate if we need gloves. We know shoe rules, and we know the closing. We know all those. So what we have to focus on is this, right? Learning about the wheelchair itself. So if you look at page 73, I've got step-by-step instructions for you. This is a nice skill because it doesn't have a whole lot of supplies. Really a wheelchair and a gait belt. Your patient will already have shoes there. They just won't be on. For this skill, we're actually going to have to put somebody's shoes on them. So if you get this skill for the test, and I have to pick a patient for you, I'm going to look at all the people that are there to test that day. Let's say that you have transferred from bed to wheelchair. I'm going to look around. I'm going to try to find somebody about your body size or smaller. And so I'm looking around and I'm trying to figure out if I can find somebody your body size or smaller that has, see what you guys have, shoes. I'm looking for somebody with slip-on shoes. Okay, like, things that you don't have to tie. So nobody in here meets that criteria. So unfortunately, you're going to be stuck putting shoes on and tying them. But if I could find somebody that just had slip-on shoes, and I might ask, because yours look a little loose, do you just slip your foot in your shoes or do you tie them? You tie them? Okay. Okay. So the evaluator may ask you a question like that. Do you tie your shoes or do you slip in? And the reason is they're looking to make this skill a little easier on somebody. Because where do they want to be? In their pool. That's right. And they figured that you mastered tying shoes in kindergarten. We really don't need to revisit that. So the way that the evaluators pair you up actually is very, very strategic. There's nothing to chance about this. Now, if you're the patient for this, you're going to be given some very specific instructions. So if I pick you as the patient, I'm going to tell you, you're going to be laying down in bed. I'm going to have you take your shoes off, just leave them, but at the foot of the bed, but by the side of the bed, lay down in bed. You're going to be pivoted around, so you're sitting on the side of the bed. I want you to be you. Don't go all limp noodle, okay? But don't help them either. Just let them do what they need to do. But once you're sitting up, you're you, right? Don't try to fall over. The care plan, which we're going to read together in a second, is actually going to tell you that the patient can sit and stand with support. They just cannot take steps. So one of the problems with this skill during the test is that the people playing the patients overact this. And they just kind of go all limp noodle. And that's not what this skill is about. If somebody is a limp noodle, this is not the right skill for them. We're looking more at mechanical lifts then, or a 2-person assist, or remember, every care plan is specific to that person and their level of ability. Does that make sense? Mm-hmm. So if you're the patient for this, don't overact it. Listen to the instructions that you're given, because those evaluators will yell at you. That is not what I told you to do. You don't want to make them mad. Yeah. Especially when you're being tested, right? That's not the time you want to be yelled at. All right. So I want to bring your attention to this graphic right here. Do you see how close that wheelchair is to that patient? I've got to change that graphic. Do you see how close that is? That's not close enough. That looks pretty close. It is not close enough. That wheelchair needs to be almost touching the patient. I mean, it's got to be, like, I should be able to fit a piece of paper between the patient and the wheelchair, and probably not much else. Because the further you get that wheelchair away from that patient, the more they're going to have to take a step to get their knees up against the back of the wheelchair. And if you remember, our care plan says they cannot take steps. Okay. So close is not enough. It's got to be super close. All right, wheelchair 101. Let me go here. We're going to get the patient sitting up on the side of the bed. They're going to have socks on. And is this safe for walking?
Nope.
Okay, so once we get them sitting up on the side of the bed, we need to put shoes on the patient. Don't put shoes on while they're laying in bed, please. Shoes don't belong in bed. We're going to swing them around and then put the shoes on while they're dangling. It's important too, again, you guys are young. You get up out of bed and you go and you don't really even think about it. But as you get older, that change in position can cause blood pressure issues. Like when you're laying down, your blood is equal, because gravity, your blood is like equally distributed. When we sit you up and now your head is above the rest of your body, the blood drains from the head. And this can make somebody dizzy, woozy, a little lightheaded, until their body pressure, the pressure inside the blood vessels equalizes. When we turn somebody and sit them on the side of the bed, this is called dangling. And it's important to have your patient in that dangling position for at least 30 to 60 seconds before you try to get them up and move them. Because we've got to give that body time for that pressure to equalize. Otherwise, when you stand that patient up, they're probably going to lose consciousness. So dangling becomes very important. And as a young person, you don't really understand this or know this because you get up out of bed and you go, right? You aren't as affected by this because your blood vessels are nice and brand new. As you get older, they get older and they don't work as well. Okay. All right. So dangle your patient. We're going to put the shoes on before we transfer the patient. Slipper socks are never enough. We're going to put a gait belt on the patient. And when we put the gait belt on, it's just like ambulate with a gait belt. It goes around their waist, tag side in. You're going to fasten it, check it with 4 fingers. Make sure that it's through the second guard so it doesn't loosen up on you. Make sure it's around the waist. Make sure your patient's feet hit the floor. They may have to scoot forward on the bed a little bit for their feet to hit the floor. But make sure that their feet are flat on the floor before you lift them to a standing position. And then you're going to count to 3 and lift, just like ambulate. All right. We're going to use that same body mechanics. We're going to lift the patient, swing them around, and then ask them if they can feel that seat behind them before we sit them down in the chair. Our care plan is very specific. It says transfer the resident from bed to wheelchair. The resident is unable to walk or take steps. So if I lift this patient up and swing them around and the wheelchair is too far away and they have to take a step, then you won't get that checkpoint. And that's a very big checkpoint because our care plan says they cannot take steps. If they were forced to take a step and our care plan says they can't in a clinical setting, that means your patient would fall. Make sense? Okay. Be really, really careful with this. If the wheelchair is not almost touching the patient, it's too far away. And you guys will see that when you're going to be practicing. You will have some practice time in class today. You will see that as you're practicing. You'll think the wheelchair is close enough. You'll go to lift the patient and turn them, and it's too far away. So the experience here is what's really going to help you. This is one skill you want to practice in this room. Any mannequin skill, like dressing a resident, partial bed bath, catheter care, and Peri-Care, those should all be practiced here because you have the mannequin. Wheelchair, and most people don't have a wheelchair at home either. We have this. All right. It says that they can stand with support, so they're not going to be a lump noodle on you. Gait belt or transfer belt is required to transfer the patient, and then after the transfer, they will remain in the room. So we're going to pivot the patients to sit on the side of the bed. This is actually easier than you think it is. You can turn somebody to sit on the side of the bed that's probably twice your body weight easily, as long as you set it up right. It's all about body mechanics, and I'll show you how to do that. All right, so now let's get into wheelchairs. If the wheelchair is not in motion, it should be locked. That's a principle. Unlocked wheelchair can roll into somebody. A wheelchair with a patient in it that's unlocked and rolling is probably going to cause some damage. So it's very, very important that when a wheelchair is not currently in motion, it is locked. That could be a test question. In order to lock the wheelchair, you have these metal, levers here. Now, every wheelchair is a little bit different. Some you pull back, some you push forward, but it doesn't matter whether it's back or forward, how that mechanism acts. What matters is this little tab. Unlocked, there's a gap. It's not in the wheel. Locked, there's no gap. That metal bar presses into the wheel to keep it from rolling. So some wheelchairs are geared so that you push the lever forward to do that. Some are set up so you pull the lever back to do that. Doesn't matter as long as that bar bites into the wheel. Good. Jake, can you?
Is it going to be one of those two types that they have down there? Because
Yeah.
the ones I work with, they have foot pedal ones too, where it actually locks the axle instead of having it even touch the wheel.
Yeah, for the test, it'll be something like this. It'll be a manual one, not a foot pedal one. All right.
Checking to zoom in on the lock.
Yes, please.
There you go.
Okay, thank you. All right, so this is the lever here. if you can see on this one, if I pull this lever back, this metal bar is going to press into the wheel. Now, back just a little bit is not going to make it work. You've got to bring it back until it clicks in place, locks in place. To unlock the wheelchair, to take it where I need to go, we're going to push it forward, and that releases that lever from the wheel itself and allows us to move the patient where they need to go. Okay. All right. So anytime the wheelchair is not actively in motion, and that this is why concrete floors are not always level. Wood floors warp, so you end up with this kind of, and a patient in a wheelchair that is on an unlevel floor will run into whatever's going to stop them, which could be a wall, another patient, or in some cases, down a stairway. This was the most expensive negligence lawsuit in Florida. Was a dementia patient that was tied into a wheelchair, not monitored properly. She made her way to a concrete stairwell, which she should never have had access to, being in a locked dementia unit. Remember, we talked about that last class. The whole purpose of somebody being in a locked unit is for safety. That's why they're there. Yes, we're brushing their teeth and helping them with toileting and feeding them, but that is not why they're there. They are there for safety. So our very first priority in a dementia unit is safety. So this patient was able to make their way into a stairwell and tumble down these concrete steps, strapped into a wheelchair, and ultimately died. The facility was sued, and it ended up being the largest lawsuit monetary award. Yeah. And the caregivers that were involved in this are no longer working in healthcare. Yeah. So what we do matters. Wheelchair brakes are not a restraint. A lot of people think that if you put a patient in a wheelchair, lock the brakes, that's a restraint. It's actually not. If somebody can, self-propel, move themselves, they can unlock those wheelchair brakes and go anywhere they want to. They're now responsible for their safety. But somebody that can't be responsible for their own safety, we don't want them to be able to move about freely. If they can't see to their own safety, they can't assure they're safe, then somebody has to. Remember, safety is important. So all wheelchairs should be locked when you leave them. All wheelchairs. If the patient can go on their own, they'll unlock it and go anywhere they want to. If they can't go on their own, it doesn't need to be unlocked. Good. Questions? All right. Now, there's a different type of wheelchair I want to bring to your attention. I don't have a slide on this, but there's a different, this is actually called a wheelchair because it has big wheels. So wheelchairs have 2 big wheels, 2 small wheels. There's a different type of chair called a companion chair that has 4 small wheels. Those chairs, while they're on wheels, they're not technically wheelchairs. We give them a completely different name, a companion chair. They're actually a little bit lower to the ground, and they're designed for people who can pad. They just take their feet and they just kind of shuffle where they want to go. And it's 4-wheel drive. I mean, all the wheels turn, so it has full mobility. And your patients that can self-propel, that can't use their arms, will just pad in these chairs. The brakes are not like these. Wheelchair brakes on companion chairs are actually on the very small wheels. So because they're designed for mobility. Okay, does that make sense? So CNAs don't get to decide what kind of chair the patient gets. That's going to be in the care plan. Good. So many things that we have to take into consideration when making these decisions. Wheelchairs are a little bit higher than normal chairs. You can see the height difference there. This is kind of important. The whole purpose of a wheelchair is to make the patient mobile. I want to take the patient somewhere. So I'm going to put them in a wheelchair to take them somewhere. Well, if I'm taking them somewhere, I don't want their feet flat on the floor. Their feet have to be off the floor for me to take them somewhere. Okay. You good? Okay. All right. So because of that, wheelchairs are a little bit taller than regular chairs, and they have foot pedals, and those foot pedals are super important. If we are putting somebody into a wheelchair, we need to understand their feet will not be flat on the floor. We don't want them flat on the floor. And how is that going to affect our patient? We have to kind of think this through. So down the back of the legs are arteries and veins. We talked about the nerves last class. This is arteries and veins. Now, when you sit in a wheelchair, the edge of the seat is going to press up into the back of the knee area, which is where those arteries and veins are. Now, because of gravity pulls everything down. That blood's trying to get back up to the heart. And because there's a bend there and we've crimped off those blood vessels, the fluid in the legs is going to stay in the legs. It's going to be harder to get that fluid back up because you've got a bend and you've got crimping. So if we've got somebody sitting in a wheelchair with their legs just kind of dangling down, this patient is going to end up with swelling of the lower extremities and the potential for blood clots, because when blood slows down or stops, it clots. So when we have a patient in a wheelchair and their legs are dangling, that's no good for our patient. We want to make sure that we're putting, this is what the inside of the vein looks like when a blood clot's forming. We want to make sure that we're putting their feet on those foot pedals to support them. That relieves the pressure along the back of the knees. Doesn't really do anything for that bend, but at least we're not squishing down those blood vessels, which reduces the likelihood of blood clot formation. So when we use a wheelchair, we have to use the foot pedals. If you don't have the foot pedals, you don't use the wheelchair unless your care plan specifically tells you to. Good? All right, so let me show you why this is important. That's when you have to get smushed into the carpet. All right, Jacob,
Yes, ma'am.
I'm going to need you to zoom in on the leg rest for me. Let me show you why this is so important, that you understand this. All right, that's good. Down just a tad. Yeah, it's good. Okay, so these are leg rests here. These are foot pedals here. So the foot pedals just fold up and down, but the leg rests are kind of locked in place. There's a little catch back here. If you release the catch, they swing out to the side. And that's what we want to do if we're putting somebody into the wheelchair or bringing somebody out of the wheelchair. We want this area wide open. So we would get the foot pedals up, the leg rests out, and then we would lock our wheelchair in place using those levers. And now we can transfer a patient into or out of the wheelchair. Good? All right. Now here's where problems happen. These leg rests, they snap into place, or you unlock them and they swing to the side. They have motion. But the problem is that they're also easily removable. And in a lot of healthcare settings, these leg rests will be taken off of the wheelchair for cleaning or whatever, and then they're put somewhere, and now you've got to put a patient into a wheelchair and you don't have the leg rests. I told you, you cannot leave their legs to dangle. Go find the footrests. If you can't find the footrest, you need to notify the nurse and let her make that decision. You don't get to make it because your patient is at risk without foot pedals. You guys understand that? All right, to put these back on, there's two holes. Oops, let me go down here. So right here, you can see there's two holes. Bless you. On this post, there are two little knobs. So we position the holes over the knobs and it just slides right on. There's no locking mechanism. There's nothing to do. You just literally set it, bless you, literally set it in place. But don't ignore the fact that you don't have foot pedals, because that's what can happen to your patient. Those of you who go on for nursing need to remember that saying. Anytime blood slows down or stops, it clots. So think about laying down in bed all the time. We're squishing all those blood vessels. Blood is slowing down. What is the patient at risk for? Clots. So if the patient's in the wheelchair for too long and we're squishing all those blood vessels, what are they at risk for? Clots. Good. This is why your care plans will often tell you to change a patient's position every 2 hours around the clock, because we're trying to prevent those complications from happening. All right, so this is what I just showed you. You've got leg rests and you've got foot pedals. Foot pedals fold up and down, leg rests swing out to the side. Do not try to put a patient into a wheelchair in this position. They will trip over these and fall. So when you're looking at a wheelchair, there's 3 basic positions for a wheelchair. You've got this one when it's in use. Foot pedals are folded down, leg rests are forward, supporting those feet. This is in use. This one is in storage. So in storage, we keep those leg rests forward. We keep them locked in place so they don't swing out and hit somebody as we're moving the wheelchair. We want them to be secure, but we need those foot pedals up so that we're not, we're able to close that wheelchair without any interference. I'll show you that in just a second. So this is when stored. This is during transfers. So foot pedals up, leg rests out, wide open space that your patient's not going to get their legs tangled in. This could be a test question where they give you a scenario. You're getting ready to transfer your patient into a wheelchair. Which of these images or graphics illustrate how the wheelchair should be set up prior to transfer? So you need to kind of know this. Okay. So if we're going to move a wheelchair to storage or from storage, if I have the leg rests out like this, they can kind of flap and hit something and cause injury. So generally speaking, during transport, you want the wheelchair like this. Now, if I'm going to store the wheelchair, I'm going to lift up on the center of the seat and bring those 2 halves together. Notice those foot pedals aren't clashing. They're in the upright. They fit together just perfectly. To open it, I would just lift up on the handles and pull it apart. That's all we have to do. Now, if I had those foot pedals down and I tried to close this wheelchair, those foot pedals would clash and we end up breaking the wheelchair. So try not to do that. Okay. Good. All right. We talked a lot about CNAs doing things they've been trained to do and only things they've been trained to do. This is a scenario that tells you what happens when you ignore that. And I feel so bad for this worker. I really do. I feel so bad. This is one of those times when a good deed did not go unpunished. So there was this older woman who was there with her daughter. She was having some x-rays taken. It was basically like a walk-in radiology at a hospital, right? So the older lady, the patient, goes in, gets her x-rays taken, no big deal, but she's in a wheelchair because it's hard for her to walk long distances. So she goes in, she gets her x-rays, they put her back in the wheelchair, bring her back out, and the daughter goes to get the car because the lady can't walk too far. So the daughter goes to get the car, brings the car out front, and somehow let the receptionist know, okay, we're here, I'm ready, or the receptionist saw the car. I don't know how all that happened, but the lady is sitting in a wheelchair, the patient. The daughter's in the car right at the front door. Some sense of urgency here because now the daughter's blocking traffic. The receptionist is waiting for a transporter, somebody who is paid to take this lady out and get her in the car. They've been trained for that job. The receptionist has not been trained for that job, but she has a sense of urgency. We got to get the lady into the car. So she's like, I know my way around wheelchairs. This can't be too difficult. I'm going to help out here. This is somebody who really wanted to do a good deed. And she took the lady in the wheelchair out to the car, but she had not been trained. And she did not know the importance of folding those foot pedals up and moving the leg rests out of the way. She did not know the importance of locking the wheelchair before transferring somebody out of it. And as she lifted this lady, the lady's feet got tangled up in the foot pedals, and the wheelchair moved because it wasn't locked. The lady fell, trapping herself between the curb and the car, and ended up breaking her leg. They sued. And they won. And it was a very big settlement case. Because this is somebody who was performing a task that they had not been trained to do. Now, I feel bad for the worker because all she was trying to do was help, right? Now, we can feel bad for her all day long. Does that bring this lady's leg back? Does that erase this verdict? When I say if you have not been trained to do something, I don't care how well you think you know the situation. If you haven't been trained, you can't do it. Period. Period. Does that make sense? I can't stress this enough, guys, because you are going to have situations that you're going to get in, that somebody's going to ask you to do something that you have no training on. And you're going to think, well, I've seen a million people do it. I can do it. I mean, it's not that big of a deal. I'll take care of it. No. Because if something goes wrong, you're the one on the chopping block. Does that make sense? This is so important, guys. So, because this is going to happen to you. You will be asked to do something that you have not been trained to do. Your only answer is, I haven't been trained to do that. Okay? Now, training doesn't have to be in a classroom. They don't have to send you to school. It doesn't have to be in a group setting. Training could be, okay, come with me. I'm going to show you how to do this on this patient. And now you've been trained. Okay, good, good. The real problem here is that you don't know what you don't know. That lady knew kind of how to work a wheelchair. What she didn't know were all the safety components or steps that were important to prevent a fall. She didn't know that. And yet that was the most important thing for her to know. But you don't know what you don't know. Think about that every time you're asked to do something that you haven't been trained to do. There's always a part of that skill that you just don't know about because you haven't received training. Okay. If you notice, most of what I teach you in here, I kind of rush through the things I know you've been trained on. You know how to brush teeth. You know how to wet a toothbrush and put some toothpaste on it, stick it in the mouth and brush. You know how to do that. What you don't know is all the ways that can go wrong. And that's what I focus on. So what I'm training you is, it really isn't about what to do. It's about knowing what to do when that goes sideways. That's what training is all about. All the little details that you don't know. Okay. Good? Mm-hmm. Good. All right. This is horrible. All right. So to do this skill, we're going to prepare the wheelchair. We're going to flip up the foot pedals, move those leg rests out of the way. We're going to get it in position close, but not too close yet. I still have to swing that patient around so they're sitting on the side of the bed and let them dangle there so I can get that gait belt on and their shoes on. So I don't want that wheelchair super close because as I swing them, their legs are going to hit the wheelchair. Somebody's going to get injured. So close enough to grab, but not close enough to be in the way. But I've got it prepared. So once I get the patient pivoted on the side of the bed, I'm going to talk to you about that in just a minute. Once we get the patient pivoted on the side of the bed and dangling, then I can get their shoes on and their gait belt on, and I don't care what order you do that in. Nobody does. Just get their shoes on and get the gait belt on. Make sure you check the gait belt with 4 fingers. But do you see how I'm positioned here? One hand is under the shoulders, grabbing that furthest shoulder. The other hand is over the knees. Now, this is how you pivot somebody onto the edge of the bed. Where most people go wrong here is they try to do this. This is a honeymoon carry. We're not that close. Putting my hand under the shoulder is going to help me move her top half around. Putting this arm under the legs would mean I'm pushing and pulling at the same time. And do you see what that does to my back? That's not good for me. So what I want to do instead is put this arm under the shoulders, just like we did before, but this one is going to go over the legs. And when I do that, it's a smooth pivot. Both hands are moving together, not push and pull. So this arm is the one that's important, the one over the knees, not under the knees. And you can actually move somebody much bigger than you. When you do this, you want a wide base of support, legs spread apart, and ideally, as long as your bed is locked, you can brace your legs against the bed for additional torque. It actually improves your strength to push. So this arm would go all the way underneath the shoulders. Just show you on her. All the way under the shoulders, and this one goes over the knees. And on the count of 3, we're going to pivot. 1, 2, 3. Just like that. Be careful because she pinches. All right. This is a live patient skill. You're not doing this on the mannequin because they don't dangle. Once you get the patient sitting on the side of the bed, put their shoes on, make sure they're fastened appropriately, put the gait belt on. We're going to bring the wheelchair close. Now, this is still too far away. Close is close. I mean, this seat should be really, really close to that patient's leg. If I stand this patient up, think about where their feet are, right? If I stand the patient up and pivot them, their feet are here. That means that they can't feel this chair behind them. Close. Before we lift our patient, we're going to lock the wheels, make sure the gait belt's in place. We'll use that same oblique standing position. We're going to have them put their hands on our shoulders. On the count of 3, we're going to lift. 1, 2, 3. We're going to pivot them around. And when we pivot them, the back of their knees should be able to feel that seat. When they feel that seat, I usually tell them when you feel the seat behind you, say sit, and then we can lower them in the chair. You can also, after you pivot them, just ask, can you feel the seat? And help them sit. Controlled, don't just flop them down. Controlled lowering. Then you're going to put their feet on the foot pedals, lock the leg rests in place. We'll remove that gait belt. Make sure your patient's backside is against the seat. They're positioned appropriately. When you remove the gait belt, don't pull it against them. And when we leave them, now our care plan says they're going to stay in the room. But do you really think they want to face a wall? They probably want to look at the TV or the doorway or the window or something. But if you leave them just facing a wall, they might feel like they're being punished. How many of you guys ever had to stand in the corner when you were a kid? So get them turned around so they're facing something interesting. and then we'll do our closing. Any questions on that? All right, Jake, can you show transfer to wheelchair, please?
Hello.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gait belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? Bed is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees, bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe. And the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gait belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gait belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard. I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3.
Sit.
And we'll remove that gait belt. Okay, and I'm just going to bring the gait belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward, make sure it locks into place, and then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If
Thank
you need
you.
anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gate belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done.
All right. Any questions on that skill? Questions on that one? We're going to go ahead and take our break since it's time. Not doing too bad. I'm only 3 minutes late. We'll go ahead and take a break. When we get back, we're going to go through feeding, Peri-Care, and then the final range of motion,
Patty,
which
we
takes
do have
2
a
minutes.
question real quick.
Yes. Question, can you get the call light after you wash your hands? It's a great question, Tanny. We have to think about infection control, right? We're washing our hands at the end of the skill to make sure that we don't take any patient pathogens outside of the room. If you wash your hands and then give the patient the call light, you're now encountering their pathogens, which means when you leave the patient environment, you're going to take the patient's pathogens with you. That's why the very last action of every single skill is to wash your hands to make sure that your patient pathogens stay in their environment. You're not taking them out with you. So the answer to that is no. Hand washing should be your very last action. Thank you for your question. All right, let's go ahead and take our break.
I said, okay, thank you.
And 15 minutes.
Testing. 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 All right. Yay, we got the audio working. Yay. All right. My tech wizard over there. I would not know what to do without him, let me tell you. I tried to do this for about 1.5 years by myself, running all the tech by myself and teaching. It was not good. Don't go back and watch the original ones. Don't. They were bad. All right. Any questions before we go on? No? We're going to jump into feeding. This is not a hard skill. You guys all know how to feed somebody. This is, I mean, there's just, it's not a hard skill. The mechanics of feeding, make sure they're sitting upright. You're going to feed slow, spoon only half full, give them time to chew and swallow. We're going to talk about some other things too along the way, but the mechanics of feeding, I mean, you guys know how to do that. That's not what we're going to talk about. I'm going to show you how, yes, but that's not really where this conversation is going to be focused. If you look at the principles involved, there's nothing to learn, right? We know to follow the care plan. We know to do our opening. We know to evaluate if we need gloves. We're not going to use a barrier for this because our food tray is the barrier, but we don't want to hold linens against our uniform because we need a towel to put over our bib, or we don't call it a bib, clothing protector to put it over them. And we know to do our closing, right? There's nothing new there that you guys need to learn. But what you do need to learn are the skill-specific steps. And that's what we're going to focus on. Again, the how is not the focus here. A lot of this is going to have to do with the why and the knowledge behind the how. Good? So our care plan at the top of the page, on page 109, tells us to feed the resident a snack who is unable to feed himself or herself. The resident is sitting in a chair in an inappropriate position for eating. You want to underline that or highlight it. Our care plan is saying, I don't care what your eyes are telling you. This patient is in an inappropriate position for eating. Care plans in a clinical setting are not going to say this. They're going to rely on your eyes. But here's your problem. Anybody ever see a 12-year-old? You guys know what 12-year-olds are? Most 12-year-olds do not eat like this. They eat like this. Now, if you're familiar with 12-year-olds and you've seen this, this probably does not look like an inappropriate position for eating. But it is. Your patient needs to be sitting up. Now, I bring that up because during the exam, this is a live patient skill. You will be feeding a live person. One of you will be the patient for this. When you are the patient, you're going to get some very specific instructions. That evaluator is going to tell you, number one, I want you to sit in that chair and slouch or slump. Number two, take 4 bites and then say you're done. No matter what, just no thank you, you're done. Okay? Those are the 2 pieces of information you will get if you were a patient. Now, your idea of slumping might look like this. If you're the CNA, this probably doesn't look too bad. So your brain may not tell you that's inappropriate. The care plan does. So I don't care what your eyes tell you. For the test, you have to ask that patient to sit up straight. It is a graded checkpoint, and it is a heavily weighted grading checkpoint. But the problem is, because you guys are the ones that are patients for this, you're probably not going to overact it. You're not going to get all like, you know, something like this that's going to be visually screaming at you that it's not appropriate. Does that make sense? Okay. So ask the patient to sit up straight. That is the most important step for this skill. Make sure your patient is sitting up for this skill. It also tells us to document the intake on the food and fluid intake form. You can see a sample of that in the second column there. And again, you would have full-size versions of this on page 169 in your book. This skill I teach at the end of the program because it does not follow our normal rules. This is a total outlier. And there's a good reason it doesn't follow our rules, but it doesn't follow our rules. So remember that we close the privacy curtain for pretty much every skill except this one, because eating is a social event. You want to engage with others. You at least want some visual distraction. You, if you're eating alone, you're probably watching TV or reading. If you are in a group, you're probably kind of looking around. If you're at a restaurant, you're not just focused on your plate and not looking at anything else, right? You're looking around. You have to have some sort of socialization while you eat. Otherwise, your intake drops. We actually, COVID turned out to be a huge experiment with this. And they've done a lot of studies on this. During COVID, one of the things that we did was close down all facilities. There weren't, you couldn't go in and visit your loved ones in a facility. They were staff only. That was it. Those were the only people allowed in. And your patients weren't allowed to go into the dining room. They were eating in their own rooms. So what this did is it socially isolated your patients. And collectively, there was weight loss among long-term care residents with COVID. And they're directly attributing it to the fact that there was no socialization. You have to think about our culture. Almost everything that we celebrate with food. Baby showers, what's there? Food. Birthdays, food. Weddings are planned around the menu, food. Funerals, what do we bring? Food. Graduations, food, right? So there are food items at almost every one of our social celebrations. In fact, we will even create reasons to gather and have food. Backyard barbecues, pool parties, neighborhood social gatherings, right? We create reasons to gather together to have food. Socialization and food go together. If you aren't socializing your patient and you're feeding them, you are only doing half the job. And your patient will stop eating because it's awkward. It's awkward. This is the hardest skill to be a patient for. Now, we're about to learn Peri-Care. And I'm telling you, this is a harder skill to be a patient for than Peri-Care. And the reason for that is psychological. Eating is the very first skill you become independent at. The very first one. You learn how to hold your bottle before you even know what hungry is. You are picking up diced peaches and Cheerios off of a high chair tray and getting them into your mouth before you can fully sit. Eating is the first skill we become independent at. And when we lose the ability to feed ourselves, it affects us psychologically in a way that no other skill can. You are much more likely to be able to rationalize somebody helping you get cleaned up down below than to be fed. Being fed is a very difficult thing for patients. So if we have a caregiver that is rushing through it, standing over the patient, not talking to them, and generally acting like this is a total imposition, your patient will stop eating. And there's a very high rate of failure to thrive among patients that have to be fed. Very high rate, which means that if they have to be fed, they probably will die within about 6 months. It's not because they have to be fed. It's because the way we're feeding them. What we do here matters. Okay? So if we're in a position where we have to feed somebody, there's some rules. One of them is that if possible, patients should be fed in a group setting where there's opportunities for observation, for conversation. Group setting is best. If you're feeding one-on-one, you must sit. You cannot stand over somebody. There's a power dynamic there. You cannot stand over somebody and shovel food into their mouth. It makes them feel rushed. It makes them feel like they're in imposition, and they simply won't eat very well. So you have to have a seat. And most importantly, you have to have a conversation with them. Now, for the test, the conversation doesn't have to be real. You can make something up. It's fine. But in a clinical setting, it needs to be real. Look around. Look around. Are there pictures out that we can talk about? Are there mementos, in their environment? Wow, that's a really neat vase. Where did you get that? You can talk about their upbringing. Where did you grow up? Can you tell me what life was like when you were a teenager? Or, oh my gosh, I've got young kids and they are driving me insane. Did you have children? How did you survive this? Let them tell their stories. Everybody has a story. You're just looking for an opening to tell it. Have you ever stopped to think about why you keep memories? Why do you keep memories? Why do you create memories? It seems like a whole lot of brain power for something that doesn't really give you any benefit. Why do you keep memories? Okay. For personal recollection, but in reality, you probably aren't going to think about those memories unless they're triggered. Most people don't just sit down with nothing to do and kind of go through their memories. Like, you don't sit down and think about a birthday party you went to when you were 12. There would be no reason to, right? There has to be an impetus. There has to be a reason that you're recalling that memory. The reason is, what did you say? To pass it on. That is the reason that you create memories, is to pass them on. It's really the only reason. You might get some enjoyment out of the memory, but the real reason is to pass it on. So how unfortunate would it be to get to the very end of your life and you have these memories and you have this drive to pass them on and nobody wants to hear them? Nobody's interested. Your life would feel completely worthless. Why did I have these experiences? Why did I collect these memories if nobody cares? That's unfortunate. We can do better than that. So having a conversation with a patient, especially during eating, is super important. Now, for the test, you're not really going to connect with whoever you're feeding. You've only got, a couple of minutes here. So for the test, you can make something up, like they're going to show a movie on the big screen later today, or they're playing bingo and the jackpot's like over $2. Can you believe it? Mabel thinks she's going to win. What do you think? You can make something up for the test. That's fine. But in a clinical setting, have a real conversation. Okay. Another reason that this skill is a little bit different than others is that we're not going to use the barrier, because our food tray becomes our barrier. Good? So it doesn't follow our normal rules. So the first thing we're going to do is make sure our patient is sitting up. And for the test, all you have to do is ask them, hey, can you sit up straight, please? That's how we're going to start this. We're feeding a single serve pudding or applesauce cup. That's what we're feeding somebody. Single serve pudding or applesauce cup. Now, this is, think about pudding and applesauce. Think about the consistency. On your tray, you're going to have a fork and a spoon. Which one do you think you should use? Spoon. That is a graded checkpoint. I don't know why. Who is out there trying to feed applesauce on a fork? I'm not sure, but it is a graded checkpoint. Use a spoon. We are going to offer a hand wipe and a clothing protector before we feed them. The hand wipe is important. Even though we are feeding the patient, it doesn't mean that they're paralyzed. It doesn't mean that they might not bring their hand up to wipe food away from their face if it's dripping down. So you don't want dirty hands up around a face when we're feeding somebody. So give them a hand wipe. It's also part of ritual. Most people wash their hands before they eat. It's part of the eating ritual. I do. I won't eat unless I've washed my hands, because I know all the things I've touched. So eating usually goes with hand washing. If your patient can't get to a sink to wash their hands, let's at least give them a hand wipe, and that helps with stimulation of appetite with that ritual. Okay, good. You're going to sit facing the patient while you feed them, and we're going to offer a drink before feeding and every 2 to 3 bites. Now, this you may not have really thought about. Everybody has different eating preferences. Some people eat all of one thing before moving on to another thing on their plate. Some people kind of graze. They eat a little this, a little that, a little this, a little that. Some of you like your corn and mashed potatoes mixed. Some of you don't. Some of you don't like your foods to even touch on the plate. That's not cool, right? Some of you will eat your salad before a meal. Some of you eat your salad after a meal. If you're European, it's usually after a meal. Some of you well, let me tell you the strangest one that I've ever seen. I had no idea this existed. I learn things all the time. There was an older woman who was in a dementia unit in a facility that I was working at, and she was a pretty good eater. I mean, she would eat whatever you were feeding her. She was a feed, and except she would never eat anything that you brought to her mouth directly, like pizza or sandwiches or, tacos, anything that you picked up and brought to her mouth. And we finally asked her, her daughter came in and visited. Now, this woman was like over 100 years old. She was very, very old. And this is back in the late 80s, early 90s. Okay. So you have to think about her upbringing. Like if this was, let's just say 1990, and the woman was 100 years old, when was she born? 1890. So that means, yeah, I know that's hard to envision, right? That's like 2 whole numbers back, right? So we have to think about, was life different in the early 1900s than it is now? Sure. Yeah. In fact, they wouldn't recognize this. No. That's one of the conversations I'd love to have with older people. What kind of changes have you seen in your lifetime? And what's the one that surprises you the most? And we would think it's probably something like, well, they send rockets up every week, or you all walk around with TVs in your pocket, or we would think it's technological. But almost every time somebody answers that question, it has to do with the way we treat each other. That's what they focus on. Have some conversations with your patients. It'll be eye-opening to you what their mindset is versus ours. It's very interesting. But anyway, we had this one lady that wouldn't take a bite out of anything. We asked her daughter when she came in, what's up with that? And she says, oh, so my mom grew up on a plantation. And this was obviously after the Civil War, but not too long, right? One generation. And back then in the Deep South, women did not take bites out of food. That was unseemly. You did not do that. Everything must be cut up and presented on a fork or a spoon, on a utensil. And this was just part of her culture. Now, I had never heard that. I had no idea. But when we started cutting up things like pizza and giving it to, she would eat it. Now, the thing is, you don't always know your patient's mindset until you learn about it. And these cultures that are different than yours are fascinating. Always take the opportunity to learn. Don't assume that your way is always the right way. It may be right for you, right? But there are other ways, and learning about those other ways can be fascinating. So I always ask, so those are 2 different questions. I know they sound like the same one, but they're actually 2 different questions. So we're going to talk about the mechanical feeding, and we're going to talk about the communication. Okay. because they really are two different things. So the mechanical feeding, me getting a spoon and putting something on the spoon and bringing it to them, I'm going to get their input. Hey, how do you like to eat? Do you like everything all at one time, or do you like things mixed? You know, how do you like to eat? If they can answer me, I'm going to go by whatever. I'm just their hands. That's all I'm there to be, is their hands. So I'm going to let them lead. What would you like first? What would you like next? And I'm going to have a conversation around that. Now, throughout our time together, I'm going to focus on conversation and learn a little bit about their preferences and their likes and their dislikes. And by the time I've fed somebody for a couple of weeks, I should know that they prefer strawberry ice cream over vanilla. I should know that they won't touch okra with a 10-foot pole. I should know these things about my patients, and I'm going to learn them through the feeding process. Does that make sense? So until I learn, I've got to ask.
And then what about like surprises, I guess? Like if you were to surprise them with ice cream, you know, is that ever like is that inappropriate? You know, if they
Care plan. Care plan. I can't answer that question because I don't know the patient. So if I've got a diabetic patient, no, we're not surprising them with ice cream. If I have a patient with a respiratory condition, I definitely don't want you surprising them with ice cream because that can increase phlegm. But I might tell you, hey, Miss Mary's a little down today. Why don't you take some Jell-O, put a little whipped cream on it, and take it into her? Let's make her smile. Okay, so, but care plan, it's not a decision you can make. It's something you would want to bring to your nurse and say, hey, Miss Mary's a little down today. I'd like to surprise her with something. What can I bring to her? Okay, work together with your nurse. But I'll tell you a story about this. I had a patient who was a hospice patient. This woman I still think about to this day. I don't want to give you her name. Let's call her Katie. Okay. She was in her late 80s, early 90s. She had had a stroke, was nonverbal. She was very confused. She had end-stage ovarian cancer. So she had masses in her abdomen. She was very uncomfortable. She couldn't sit. She couldn't lay down. Any position she was in, she was uncomfortable unless she was upright, you know, because upright elongates the torso, less pressure in there, a little more comfortable. So this woman walked nonstop. You couldn't get her. Now she had dementia as well, but she was stroke nonverbal. She had this PVC walker is what they are. They're big. But it has like this little seat on it. And she would just take this walker, it's on wheels, and she would just go all over the facility. And you try to get her into the dining room to eat at meal times, and you couldn't get her to sit because she would sit for like 2 minutes and then she'd be up and wandering. Now, obviously her nutrition is being impaired, right? Because she won't sit down and eat. She's walking, which is expending a lot of calories because she's doing it all day long. So how do we get this woman some nutrition without making her sit? And I want it to be pretty high calorie nutrition because we're not going to get a lot into her. So everything must count, right? Well, the one thing, and we experimented with a lot of different things, but the one thing that I found out through trial and error is that she tended to really like chocolate Wendy's Frosties. I could get her to eat that. Now, I would walk along beside her and, you know, take a spoon and as she's walking, and she would stop and she'd take the spoon and she'd, you know, and then she'd walk a little bit and I'd give her another bite and I'd have this running stream of conversation about just stuff, right? Just for socialization. She couldn't respond to me, but that doesn't mean that she's not being entertained by what I'm saying. So I realized, okay, this works. And it's somewhat high calorie, but can we make it more nutrient dense? So what I would add to it is a scoop of protein powder and a scoop of peanut butter powder, and she would eat it. Sometimes I'd throw in a banana and blend it all up, and she would eat it. So now I've got something that I know she'll eat that's nutrient dense. And a lot of times cold items tend to be more comforting. Okay, especially when you got a lot of GI stuff going on. So this worked. And this woman lived for like months on nothing but Frosties. Nothing. You know, I doctored up, but nothing but Frosty. But as the nurse and working with the nutritionist, so every day I went and got her a Frosty. Every day. On my days off, I would go get her a Frosty and take it to the facility and give it to the nurse that's taking care of her that day to make sure that she got the nutrition that she needed. So this is why you really want to work with the nurse, because the nurse is working with the team, the dietitian, you know, and I went to the diet. What can we add to this to make it more calorie dense for her? Now, she was in stage ovarian cancer. We knew the cancer was ultimately going to take her life. We knew that. But let's try to make her as comfortable and give her as much enjoyment as we can until then. Now, why would I choose a Frosty over Jell-O? They're both cold. Why would I choose a Frosty over Jell-O? What? Okay, what she would eat. What she liked.
It's creamy.
Creamy. Softer. Nutrient dense. More nutrients. More calories. Jell-O is a very low calorie food. It doesn't have very many nutrients at all. So as a CNA, you might look at both, right? A small thing of ice cream and a thing of Jell-O, and you're making a decision based on what tastes good. The nurse is going to take that a little bit further. Does that make sense? This is why you want to work with your nurses as part of a team. Good? Make sense? All right. So we're going to offer a drink. Oh, that's where I was going with that. I knew I was going somewhere. So if we all have different food preferences, which we just talked about, we also have to realize that we have different drinking preferences. And this is the one you probably don't think about too often. Some people don't like to drink at all before a meal because they don't want to fill up before they eat. They want the room for the food, the good stuff, right? So most people, or some people, don't drink before a meal. Some people do. My aunt was like that. She would drink an entire glass of water before she ate anything because she had been a model in her teens and early 20s, and that's how you stayed thin. You filled up on the water. So she had developed that habit early in life and just kept it throughout her lifespan. She always drank. Now, it doesn't work for me. I have tried. I have drank water and I still eat. It does not work for me. But for some people, it does. Now, some people like to drink with a meal. That's me. I don't produce a lot of saliva. My mouth gets dry really, really quickly. So I drink as I eat to help with digestion. Some people drink after a meal, right? They filled up on food. Now let's add some liquid. Everybody is different. And you probably, now all of you guys are starting to think, well, wait, how do I do this? And you probably really didn't think about it too much because it's habit. It's a habit you developed early that you do daily without ever really even considering it. So we have to understand that if we have different drinking preferences, so do our patients. So for the test, we're going to offer them a drink before we feed them. They may take it. They may not. I don't know. It's up to them. So I would ask you, would you like a sip before we start? And you can say yes, or you can say no, completely up to you. You get to decide. Then I'm going to give you 2 or 3 bites. And I'm going to ask again, would you like a drink? And you can say yes, or you can say no, completely up to you, whatever you want. But you're in control. So for the test, we have to offer before and every 2 to 3 bites. Now, if you remember a minute ago, I told you if you're a patient for this, you're going to get 2 pieces of instruction. One, slump or slouch, and the other is to only take 4 bites and then say, I'm done, then refuse anything else. The reason you're taking 4 bites is because somebody should be offering you a drink every 2 or 3. So if we get to 4 bites and you didn't offer a drink, you're not going to get that check mark. Okay, good? Good?
You know, on the test, if it's pudding or applesauce, we don't have to go into all the dynamics of what's on the plate.
No.
You've got chocolate pudding.
Right, right. You've got I've got chocolate pudding for you here, or we've got a thing of applesauce. How does that sound? For the test, it's just one thing. It's easy, but I do want you to know for big plates.
Sure.
Yeah. So here's another one that just, I still think about this, makes me absolutely crazy. Your assumptions can get you into trouble. So was working in a nursing home. I was a hospice nurse, went into one nursing home every single day, saw my hospice patients, but they lived in the nursing home. And I had this one lady, we'll call her Mary. She was in the dining room. She was a post-stroke patient. She had something else that was why she was on hospice, but she was nonverbal because of a stroke. And she was very with it. She was not confused at all. Her brain was very with it. She just couldn't speak. And her face was so expressive. I mean, she didn't need words. You knew what she was thinking on her face. Okay. Now, because she had had a stroke, she had some swallowing difficulties, which meant that everything was pureed, chopped up really fine, so she didn't have to chew. And the CNA is sitting there feeding her. I come up to the table and hey, Mary, how you doing today? And I look at the plate and it's this big gray glop of goo. I mean, just gray goo on the plate. And I'm like, what's that? And Mary she looks at me, her eyes get all big and she rolls her eyes and turns her head away. And it's very obvious she doesn't want any part of that gray goo. Okay. So I asked the CNA, what's for lunch today? She says, oh, Salisbury steak, mashed potatoes, and beets. I said, okay, well, what's that? She said, Salisbury steak, mashed potatoes, and beets. I said, that? She says, yeah, I mix it all together. It's pureed. They can't taste it anyway. I said, oh, no, pureed does not mean no taste. It means no chew. You're confused. I said, would you eat Salisbury steak, mashed potatoes, and beets mixed together? She says, oh, no, that's disgusting. Yeah. And you're feeding it to somebody. Go get her a new tray. Don't make the mistake of thinking that pureed doesn't mean no taste. Bland means no taste. Pureed, all the taste, none of the texture. So don't just mix stuff together. Now, some people do want their eggs and cheese grits mixed together. Perfectly okay. If that's the way they want to go. Me, no, thank you. But if that's the way they want to go, that's fine. Let's get some input from our patients. And if our patients can't give us input, don't go mixing stuff. Don't be a chemist.
So I don't want to open a whole can of worms, but like if my mom says one word, she chokes on anything. So on the care plan, the nurse will probably already know if that patient, you should probably talk to them while they're eating or.
Go by your care plan for each patient. I can't give you specifics on that, on your mom's situation, because I don't know.
Well, no, like a patient.
Right.
Yeah.
But if we've got somebody who is prone to choking, your care plan is probably going to say feed very slowly. Very slowly. So in that case, I still want them socialized, especially if socialization options are very limited. So I still want them socialized, but I don't want them talking while they're actively eating. So we're going to give a bite, let them chew and swallow, and then we're going to have a few words. Let it digest, let it go down, because if they're choking, that means that they probably have esophageal strictures or motility issues, which means the food doesn't just slide down into the stomach like it does for you and I. It kind of has some roadblocks set up. So it takes some time to get down. So having some words in between bites to let that food go down will probably help with that choking reflex, because our esophagus isn't full when we're trying to swallow the next bite. So again, it's a case-by-case basis, but you would go with care plan for that patient. Okay, good. Makes sense? All right. Feed slow. Spoon should never be more than half full. Remember, for the test, we're only giving 4 bites. And your spoon is only half full. So 4 bites, half spoons. We're not feeding a whole lot here, guys. Not at all. Have a conversation. We talked about that. And then at the end, after they take their 4 bites, they're going to say, no, thank you. I'm done. I'm full. I don't want any more. I don't know what they're going to say, but they're not going to want to eat anymore. And that's fine. We're not going to say, oh, thank God, I got a million things to do and you're keeping me from it all. We are going to be encouraging. And I use 3 forms of encouragement. You should use at least 2. The first thing I'm going to say is, are you sure you don't want just one more bite, please, for me? Just one more? Again, turn up that charm. The more charming you are, the more you can get them to do for you. So one more bite, please. Sometimes I'll even say, oh, Miss Mary, please take a few more bites. I've got to sit here for a few minutes because my feet are killing me. You'd be doing me the greatest favor. Just take a couple more bites so I can stay. You know what that patient's going to do? They're going to take a couple more bites because they think they're helping me. Oh, yeah. I have no shame here. I will use anything I can to get some nutrition in them. Absolutely. But be encouraging. The second thing I'm going to do is offer to get them something else. We've all had these days. I just had one yesterday. I thought I wanted something. I made it. I took a bite and I'm like, nope, not it. That is not what I wanted. We've all had those days. Well, if it's not your kitchen and you can't go in and make something else, you're kind of stuck with what you got and it's just not doing it for you. You're not going to eat very well. So when somebody stops eating before the tray is empty, I'm going to ask, can I get you something else? Is this just not doing it for you today? Can I get you something else? And then try to find them another alternative. Again, nutrition is important here. The third thing I'm going to do is remind them that food is available. They may not know that. It's not their kitchen. They may not know that I have a snack center that has goodies. If you get hungry, you're not eating well right now, but if you get hungry in a little bit, let me know. I can rustle up some graham crackers, maybe some peanut butter, maybe even a couple apple slices in there. Just let me know what you need. But I will always make sure that they know food is available. When you do these things, it seems like feeding them is less of an imposition and more of an act of kindness. Okay. I'm telling you, if you can get your patients to feel like they're doing you a favor, they will go to the ends of the earth for you. If it benefits them, that's a wonderful thing. You can use that. Leave the mouth clean. This is just like mouth care and denture care. This is the step that gets missed the most. Wipe off their mouth after you feed them. Even if nothing looks like it's there, there's probably something there. It's why we have napkins. Okay. And then we do the closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Make sure the environment's clean. The call light is in reach. Oh, well, the curtain's not closed. And then go wash your hands. This is a documentation skill. So we're going to document after washing our hands. And then we're going to document again. Or I'm sorry, then we're going to wash our hands again after documenting. But let's talk about documentation. So this is the form that we're going to use. The first thing is snack or meal. What does our care plan say that we're giving them? A snack. So which one of those do you want to check off? Snack. Yeah. A cup of pudding is not a meal. But to some people, it could be. Our care plan says snack. So that's what we're going to put. And then it's got a scale there. It has 0, 25, 50, 75, and 100. And it asks us to estimate the percentage of food the patient ate. So if we only gave them 4 bites, and each bite was a half of a spoonful, based on that, based on this, 4 half spoonfuls of pudding or applesauce, how much do you think they ate? What do you guys think?
Yeah, that's true.
Okay, so that's right. So you would want to see what we started with, right? It's hard to gauge unless we know what we started with. So when we're doing food intake, we always look at what we start with to estimate how much your patient ate. Now, this isn't a hard and fast concrete thing. This is a judgment. If they didn't eat anything, if the tray comes back same way it went out, it's 0. They refused it. If they picked at it, moved some stuff around, maybe took a taste, it's still 0. Not enough to count. If they ate some, but not half, okay, a couple bites, some, but not half, it's 25%. If they ate about half, then it's 50%, about half. If they ate most, but they're not a member of the Clean Plate Club, it's 75. If they ate all or almost all, we can give them 100. This is estimation of percentages. I don't want to see 62%. It's 0, refused, 25, picked at it, some, 50, half, 75, most, 100%, all. Okay, good. All right, so for the test, a standard size pudding cup or applesauce cup, it's going to be 25%. That's what you're going to document. If you, I know what they're using on the, I know how big they are. If you are giving them half of that cup in 4 bites, you overloaded the spoon. Don't do that. Good? Questions? So let's take a look here at this activity. Using this quarter scale, this is what we start with at the top. We have a sandwich, some broccoli, and Jell-O. I don't know who puts broccoli with sandwiches, but let's go with it. We have a sandwich, broccoli, and Jell-O. You go to pick up the tray, and the first plate is what you pick up. They picked at it. They had a couple of bites of the sandwich, a little bit of the broccoli, and just a couple cubes of Jell-O. How much do you want to give them credit for here? Yeah, probably about 25%. Yeah. The second one, they ate about half of the sandwich, about half of the broccoli, about half of the Jell-O. What do you want to give them credit for? 50%. Down here at the bottom, we got 1 broccoli stalk left, some bread crust, and a little bit of Jell-O. What do you want to give them credit for? Probably about 75%. Yeah. Now, this last one's tricky. It's not the Clean Plate Club. There's still something left, like a broccoli stalk and 2 pieces of Jell-O. It's not the Clean Plate Club, but do you think it's close enough to call? Yeah, I don't think broccoli stalks count. Okay. So even though it's not everything gone, it's close enough to call. You guys see that this is kind of a judgment thing? You wouldn't be wrong if you put 75%, but it's closer to all than it is to 75%. Make sense? So closest to. Now, this isn't scientific, guys. This is an estimation. Now, where we look at this, I'm not looking at this on a one meal situation. I'm looking at this as a overview, a general thing. So when I go to the patient's intake, I'm scanning over the last week or the last month and kind of seeing where they're at. If they were at 75, 100, 100, 100, 75, 100, 100, 75, 100, 25. What does that tell me? There's a change. Something is wrong. Something is going on with this patient. If you just come to me today and say, yeah, Mary ate 25%, I'm going to go, Okay, and I mean, yeah, what was she eating before? Because if that's all she ever eats, 25%, nothing has changed. So we use meal percentages as a general overview. Does that make sense? Okay. It's not granular, it's big picture. And that's why we're just going to estimate. Now, that's different from liquids. Liquids, we use a totally different situation with. Okay. But I need you to understand that food is generally going to be estimated. Now, for the test, we're also going to estimate the liquids as well. And you can see that on your documentation sheet. It has the quarter scale for food and then the quarter scale for fluid intake. So on page, what page is that where the scale is? Yeah. Okay, so 109 with a step-by-step. You can see the documentation form there. Okay, so for the test, if they take a sip or two of the drink, of the water, you're going to give them 25%. If they drink half the cup, you're going to give them 50%. If they drink most of it, you'll give them 75. If they drain the cup, give them 100. Okay, it's just an estimation. But in reality, when we're doing liquid measurements, we usually measure scientifically. And scientific measurement is usually based on the metric system. So ounces have to be converted to cc's in order to get our scientific measurements. So if you look at a container of like pre-packaged liquids, so like that water bottle there in front of you, that water bottle probably says 15.9 ounces. Okay, and then right next to it, it has mLs, and it probably says 500 mLs, right? Okay, that brisk can, you've got 12 ounces. Well, how much? 355, right. So a pre-packaged, so your Capri Sun back there, how many ounces? It's probably, I'm thinking that's probably 6 or 8 ounces. I'm not sure. Most prepackaged, it's on there somewhere. I just don't know where. Most prepackaged liquids are going to have the amount of ounces because we're in America, but also the amount of cc's, because if we're going to be measuring scientifically and documenting scientifically, they're going to do the most accurate measurement for us. So if we have a prepackaged, we always go by the package. Make sense? Whatever mLs are on the package. mLs and cc's are the same thing, to two different names. Remember, in healthcare, everything has two names. I don't know why. All right, cc's, mLs, same thing, just two different names. So if it's prepackaged, we're going to go by the package, but most things in healthcare aren't. Most things in healthcare, most liquids in healthcare are going to be cups that they bring to the patient on the food tray, a coffee cup or a water cup that's on the patient's bedside, right? They're cups. So how do we do that conversion? Because the cup doesn't tell us how many mLs. So when you go to work in a clinical setting, during orientation, they're going to tell you our coffee cups are 8 ounces. Our water cups are 6 ounces. Our juice cups are 4 ounces. Or they're going to tell you, and you need to know that. You need to write that down because it's going to be important when you're doing your intake and output conversions. So 1 ounce is worth 30 cc's. So for every ounce, we have 30 cc's. If we have 6 ounces, we multiply 6 by 30 to get 180. If we have 8 ounces, we multiply 8 by 30 to get 240 cc's. So that's how we do the conversion. You will have one math question on the state exam, and it's usually conversion.
It'll tell you your patient took in 12 ounces of water this shift. How many cc's are you going to document? Now, there is a different type of math question that you might have. Still has to do with this, but I'm going to show you that. If you look here on page 106, there's a couple of activities there for you to estimate percentages, but this is the part I want to talk about right here at the bottom of the second column. You'll see a cup there that says 6 ounces of juice. I can't read it. How many mLs would that be? 180. So write 180 in that box, in that line, 180. Now, our carton, remember, if it's prepackaged, we go by the number on the carton. So how much does that carton say? 240. So write that on that line. And then we have 12 ounces of coffee. Well, I need 12 ounces of coffee. How many mLs would 12 ounces of coffee be? 360. So write 360 there. Now, at the end of your shift, this is what our patient took in today for liquids. At the end of the shift, we have to add all of this up and come up with a total intake number. So we would add 180 plus 240 plus 360 to get our total intake number. And if you add those three together, you should come up with 780. And that's what we would document under intake for that shift. Now, you're not the only one measuring intake. You're measuring oral intake. CNAs, that's your domain, oral intake. But sometimes nurses use IVs and IV medication, and they will document that. They may irrigate wounds, and they would document that, the amount of liquid they use. So intake is going to be, total intake is going to be comprised of the oral intake that the CNAs list and any additional intake that's put in through some sort of a tube in the body. That's going to be documented by nurses, but at the end of the shift, all of that is going to be added up into our total intake for that shift, for that patient. Now, we don't measure this for absolutely every patient. Most patients don't need this. You guys don't need, you don't keep track of how much fluid in and how much fluid out. You don't, why would you? We only do this if we have a fluid balance problem or a suspected one. So not all of your patients are going to need you to do this measuring. But if your patient is on something called intake and output, so if you go to page 107, it's going to talk to you about intake and output. If we are measuring intake, everything that goes into the patient orally, we have to measure what comes out of the patient. So that means you're measuring their urine. Or if they're vomiting, you might be measuring their vomit. Or if they have liquid stool, you might be measuring that. If it's liquid and it comes out of the body through a natural opening, a CNA is going to record it. If it comes out of the body through an unnatural opening, like an incision or a drain or something like that, chest tube, that would be measured by the nurse. But again, all of that's going to be added up for your total output for the shift. So natural is documented by CNAs. Man-made openings documented by nurses. But together, it's going to make up your output. So catheter bags, yes. And catheter bags in some setting, I got to be very careful here because it depends. If your policy and procedure allows CNAs to document output from a catheter bag, which we're going to learn on Monday, okay, then you would be allowed to do that. There are some settings that require you report it to the nurse, and then the nurse documents it. So you would want to find out what your policy and procedure is for your setting. So yes, it's still urine coming out from a natural body opening. It's just through a tube. Yeah. So, and collected in a bag. So some settings will let CNAs document that. Others prefer the nurse to do the documentation. And the reason is because sometimes we have CNAs that do some really crazy things. You know, they'll document 852 cc's. Really? Really? You measured 852 cc's? I don't think so. So, because these medical records can be called into a court of law and used as a defense, they're pretty picky about what they let CNAs write in medical records. Okay. All right. So you will have a math question. You will either have to convert ounces to cc's, mLs, or you will have to add up a couple of different output or intake measurements and come up with a total. For the test, you cannot take in scrap paper, but they will give you a whiteboard that you'll be able to use and then erase at the end. All right, good? Questions? We already talked about this, so I'm not going to go over it. We talked about medical abbreviations and which ones you need to know, the ones that are grayed out. But NPO is the one that specifically relates to this lesson. NPO means nothing by mouth. All right, again, page 169 has your sample form that you can use when you're practicing, and 107 talks about intake and output. So let's go ahead and watch our video on feeding. This is a very quick video. Yep. Yeah, I know. Oh. I think I was. Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to stand up straight before we get started, please? How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you. Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game yesterday?
I was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off and we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay. I'm still muted here.
You're muted.
Oh, I am? Okay. All right. Any questions? Oops, let me go back. All right. The next skill that we're going to go over today is Peri-Care. Like partial bed bath, there's a lot of principles at play. Remember, none of these principles are going to be on your care plan. You have to know these. You have to know to do the opening. You have to know to use a barrier. You have to know when to use gloves. You have to know when to use a privacy blanket, how to handle linen. So your patient has to be in the middle of the bed all the time, washing rules. You have to know all that. So there's lots of principles involved here, but we know them all. Easy. This is a mannequin skill. You'll be doing this on a mannequin. And somebody with your level of experience should be able to do this skill in 17 minutes or less. It is the second longest skill that we have. Partial bed bath was the longest at 19 minutes. So this is a big skill. All right, our care plan tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resin is wet, but the gown and the bedding are dry. That's a miracle. It'll never really happen that way. But we're going to take the gift that the test gives us because they're trying to shorten this. It is a mannequin, so she's not really wet. We're pretending here. There's going to be a pad under her, and you're going to pretend that pad is wet. It's not really wet. You're going to pretend. So we're going to clean the front of the patient. We're going to turn them over, clean the back of the patient. We're going to change the pad before we do that, and then change the pad again after we do that, and I'll explain why in just a minute. Other than that, all the other rules that we know apply. We do have to understand a little bit about infection control here, though. And in order to understand that, we have to do a 5th grade review of the urinary system. So we've got 2 kidneys. Most people have 2. Those kidneys filter blood 24 hours a day and make urine. They never stop. They filter the blood. As the heart beats, it pushes blood through the kidneys. Kidneys take out waste products and excess fluid. The heart pumps again, and it pushes that clean blood now on, okay? Nonstop, 24 hours a day. So as the kidneys filter the blood and make urine, those urine droplets drip down tubes called ureters, and they collect in the bladder. Now that bladder has a little valve at the very bottom of it. That valve stays closed until you go to the bathroom. And when you go to the bathroom, the valve opens, the urine comes out, you empty, and then the valve closes again, and now you're ready to go about your day. It's kind of like the seal on a Ziploc bag. You can open it and close it. So
Kidneys produce urine 24 hours a day, drip, 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 drip. As those drips come down, they collect in the bladder, and the valve closed keeps the drips in the bladder until you got enough to make going to the bathroom worthwhile. As this bladder fills up, there's some nerve cells toward the top of it that respond to pressure. So as your bladder fills, those nerve cells realize, hey, we got a bit on board. Let's go find a bathroom. You go find a bathroom, the valve opens, the urine comes out, the valve closes, you're ready to go again. Got it? When your patient is incontinent, that whole system still works. Your kidneys still filter blood 24 hours a day. That urine still comes down tubes, drip, 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 24 hours a day, never stops, drip, drip, drip. Still goes into the bladder, drip, drip, drip. What is broken here is the valve. So those drips that go into the bladder, there's nothing to keep them in the bladder, so they come out. Your incontinent patients are going to be wet 24 hours a day. All the time. Drip, 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 drip. If you have a patient who is dry, 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 really, really wet, you do not have an incontinent patient. That valve was holding. That valve was working. That is not an incontinent patient. What you have are incompetent staff members who aren't taking this patient to the bathroom. That's what you've got. You don't have an incontinent patient. Incontinent patients are going to be wet all the time because this is our problem. But this is a muscle. Just like any other muscle in your body, you can strengthen it. And a lot of times you'll see on a care plan, our patient is on bowel and bladder retraining, which means we're going to take that patient to the bathroom every 2 hours around the clock. We're going to get them up out of bed. We're going to take them to the bathroom. We're going to let them go. We're going to take them back to bed. 2 hours later, we'll do it all again. And when you do this, this muscle is going to get a workout. And as it starts to get that workout, it starts to get a little bit stronger and be able to hold urine. First couple days, you're not going to get any effect of this, right? You take them to the bathroom, there's nothing there. You go back to bed. Take them to the bathroom, nothing there. Go back to bed. But over time, this muscle will strengthen, and you can help our patients regain continence by putting them on a toileting schedule. Pretty cool. So if your care plan says bowel and bladder retraining, we're trying to strengthen up our valves at the bottom of the bladder or the bottom of the bowel. Okay, don't skip it. Where this goes wrong, and bowel and bladder retraining is actually highly effective, but where it goes wrong is night shift. If you go to work in a facility as a night shift CNA, I don't know why, but night shift does not like getting patients out of bed for any reason. They think, oh, I'm just going to let that patient sleep all night. You think you're doing it for the patient, really? I can see right through that. Get your patient up. Get them to the bathroom. Don't be lazy. Because if your muscle isn't getting that workout, tomorrow when we do it, we're not really going to get much effect. It's got to be done on a regular basis. Good? Night shift CNAs. What's that?
Just like potty training the kid.
Absolutely. Absolutely. Yeah, a puppy too. Yeah, put them on a toileting schedule. Absolutely. So incontinent patients are always wet, but here's our problem. Adults are not like babies. Your urine is going to be as acidic as the foods that you eat. Because as we eat foods, and we like acidic foods, they taste good to us. So as we eat foods that are high in acid, our kidneys are going to have to pull that acid out of our bloodstream. Too much acid in the bloodstream, no good for us. So our kidneys have to pull that acid out of the bloodstream, and it goes into the urine. And this makes urine more acidic. So babies, they don't eat much acid. They eat
like breast milk and formula and rice cereal and plums, you know. They don't really eat things that are really acidic. So their urine is very mild. You can put a diaper on a baby, put them to bed, wake them up 8 hours later, they still have skin on their tushes because the urine's very mild, not acidic. Adults, not that way. You put an adult brief, we don't call it a diaper, on an adult, put them in bed for 8 hours. When you wake up the next morning, they're not going to have skin on their tushes because the acid is going to eat through the skin and they're going to have wounds. So if you've got a patient who is incontinent, we have to clean and change them every 2 hours around the clock. Well, if we're going to have to clean and change them every 2 hours around the clock and we have to wake them up for that anyway, get them up and go to the bathroom as you're doing it. Let's get some effect of this wake up. And maybe after a couple of weeks, your patient won't be incontinent at night anymore. It's healthier for the skin. Good? All right, adult briefs. Let's talk about these things. This is good when your patient is out of bed because out of bed, nobody wants to wet themselves in public. It's embarrassing. So adult briefs are going to hold in that urine. No one can see it. It's good. Remember, we still have to clean and change them every 2 hours around the clock. So don't put an adult brief on them, put them in a wheelchair, leave them there all day. That acid's going to eat through the skin. So every 2 hours, we're still gonna clean them. But here's the problem with this stuff. Adult briefs are plastic lined because we don't want that urine to leak out, right? So it's waterproof. It's also going to block out light and air. And it's going to hold in body heat. So we have warm, dark, moist, and acidic. This is like an all-you-can-eat buffet for pathogens. So when we have a patient who has an adult brief on, the likelihood of infections goes up tremendously. We also have the possibility of skin issues like rashes or wounds or fungal infections, yeast infections. So adult briefs, when they're out of bed, because it's dignity, but how often do we have to clean and change them? Every 2 hours. Now, if they're not out of bed, if they're not engaging socially, if they're in bed, there's a better way than this. And that is leaving them open to air. Open to air means no adult brief. We have a patient. I'm back on. We'll see it. I think the battery is going dead.
It's working now.
Okay. So when we have somebody who is in bed, if we put them on a pad and we allow that light and air to circulate and we kind of spread the urine out. But let's think
You have your
about
phone, you
that.
can turn the microphone on.
Let's think about that pad for a second, though. So, you guys remember what body temperature is? 98.6. Thank you. 98.6 is our body temperature. That's hot. We established that. That's hot. Room temperature, about 70, let's just say 75 degrees. Okay. So we've got 98-degree urine hitting 75-degree air, and room temperature always wins, which means that that pad is eventually going to feel like it's 75 degrees.
Anybody ever go swimming at the springs? You guys know what the water temperature is? 72. Yeah, 72 is the water temperature. When you get into the springs, what's your first initial reaction? Oh, it's cold. That's right. So we know 72 degrees is cold. We got a pad that's 75 degrees. It's not much warmer than that. What is that pad going to feel like to your patient? Yeah, cold, wet, slimy, uncomfortable. If you were laying on that pad, what's the first thing you want done? Yeah, put me on a dry pad, please. So that's the first thing we're going to do is change that pad because we know it's wet. Your patient is always wet, so change the pad out. But now you got a wet butt on a clean pad. So when we're done cleaning, we want to change that pad again. So at the end, you've got a clean patient on a clean pad for the next 2 hours. Now, some of this is going to be positional, though. And I hate that I even have to say this. When your patient is laying down like this, you have to think about gravity here, okay? Gravity is going to play a part here. When your patient is laying down, their bladder right here is laying like this. Okay? It's not standing up, it's laying flat. At the bottom of the bladder is going to be a little bit of urine that's not coming out because it's flat. Got it? What do you think is going to happen when I turn this patient on their side and that little bit of urine moves? Yeah, it's going to come out. Absolutely. So when I turn the patient over, even if I've just cleaned the front, if I turn the patient over to clean their backside, they may leak a little bit. And that's okay. They're going to leak a whole lot more in the next 2 hours. It's okay. We cleaned some of the urine off. It's okay. It's expected. It's called postural drainage. It's expected. But this is why you have to go through a training program. Because we had a young man who was working in healthcare in Florida, about 2 counties down from us, who didn't understand how incontinence works. And he was caring for patients, cleaned the patient up, turned her over to clean her backside, and she urinated. And he saw that as a sign of disrespect and beat her to death. Happened about 8 years ago. This is why I have to have these conversations with you. It's awful. But we can't assume that you guys understand physics or mechanics or have the right expectations. And yes, that really did happen. When you turn a patient over and they're incontinent, you will have a little bit of leakage. It's normal. It's okay. Please don't beat your patients. We're going to follow all of our washing rules. Melissa asked what to give the patient that has no bowel movement for 8 days. You give a report to the nurse. That's what you give. I can't answer that, Melissa. I'm not real sure about the patient themselves. What's causing the constipation? Is it a nutritional deficiency? Is it a structural abnormality? Is it a dietary issue? Is it a lack of activity? Is it a medication-related issue? I'm not real sure. All of those things are going to play a factor in the decision. So you would want to report this to the nurse, hopefully before it gets to 8 days. Really, you should be reporting it to the nurse after day 3. Let the nurse know, and then the nurse can figure out what the causes are and what the best treatment is for that situation. But I can't tell you what to give this patient because I don't know. I'm going to treat each one of those situations a little differently. Okay. All right, so we're going to follow all of our washing rules. Whatever we wash, we rinse. Whatever we rinse, we dry. If our water gets cold or soapy, we're going to change it out. To get water, we're going to use a paper towel, turn the faucet on, check it with our wrist. It should feel warm, not hot, not cold, just warm. Let your patient check it too. All of those same rules. We know all those rules. There's nothing new to learn here. The way that we wipe is going to count though. So I just did this verbally. Let's go through it on the screen. Don't add soap to your basin. Use your paper towel. Check the water. Let them check the water. Make sure that it's if it's cold or soapy, you change it out. And we're going to use the leaves method. I'm going to get to that in just a minute. This is a wet body opening. It needs the leaves method to prevent cross-contamination. Whatever we wash, we rinse. Whatever we rinse, we dry. And change the water if it gets cold or soapy. Keep your surface dry, and we don't use lotion. So here's our care plan. Female patient has been incontinent of urine and needs Peri-Care. The pad under the resident is wet, but the hospital gown and bedding is dry. I'm going to speed through this a little bit more. Here we go. All right. So the way that we clean matters. I have my washcloth. You guys remember that whole leaves method we learned last class? We have a washcloth folded in half and in half again. So we've got this little square thing, right? And instead of looking at it as a square, I'm going to look at it as a diamond with the free edges at the top. I'm going to put it in my hand, tuck in one corner between my thumb and index finger, tuck in the other corner between my pinky and ring finger, and now I'm holding the washcloth like this.
Bringing the camera closer if you'd like to display.
Okay. So we're holding it up with the leaves at the top, tucking one corner in between my thumb and index finger, other corner in between the pinky and the ring finger, and now I can clean. So I'm going to add soap to all 5 leaves. So I'll add soap here, fold it, soap, 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 and the backside soap, because I need 5 surfaces to make this work. So I'm going to hold the washcloth in my dominant hand. I'm just going to turn this around so that I can reach. I'm going to hold the washcloth. Up here at the top of the peri area, I'm going to use the heel of my hand and kind of retract just a little bit and use my fingers to kind of spread out that labia just a little bit, not a lot, just a little bit, so I can get the washcloth down the inside middle. So I'm going to hold open and wipe top to bottom. Never go back up. This is one-way trip. Just top to bottom, move away, and we'll fold that over. We don't want to do this. We don't want to go down and back up. All of our pathogens are down here in our rectal area, and we do not want those pathogens to have access to our bladder. So top to bottom, fold that over. I'm going to go down the outside of the labia, top to bottom, fold that over. The other outside, top to bottom, fold that over. And then right here, this is that crease between the leg and the groin, that indentation. We're going to clean top to bottom. Again, don't go back up. Fold that over. And then top to bottom on that side. Whatever we wash, we rinse the exact same way. Wring your washcloth out. No dripping wet washcloths. And you're going to rinse that same way. We're going to rinse down the middle. Fold that over. One side. Fold that over. The other side. Fold that over. Skin fold. Fold that over. Skin fold. And then whatever you rinse, you dry. So top to bottom. Then we're going to turn our patient over. Once we have them turned over, scoot and roll. Remember our principles. Then we're going to wash the backside. So I'm going to take a washcloth, wring it out really well, and I'm going to soak 4 corners this time. So 1, 2, 3, 4. And I'm going to wash up the center crease, just like that. Fold that over. We're going to wash one cheek. Fold that over. Wash the other cheek. Fold that over. And once more up the middle. Now for the test, this patient has been incontinent of urine, so it's just urine on here. 1 washcloth is all you need. Just trying to wash off the urine. If this patient's had a bowel movement, we're going to use the exact same process, but we may need more than 1 washcloth, depending on the amount of feces that's there. Okay? Whatever you wash, you rinse. Whatever you rinse, you dry. Same way. And then we're going to change that pad out one last time. So we have a clean butt on a clean pad, and we're ready to go for the next 2 hours. It's not a hard skill. As long as you know to always wash top to bottom using the leaves method. So you see how we're building on the things that we've learned up through the class? So this shouldn't seem like a totally new skill to you. Good? Good? Okay. All right. So once you've done your closing, there's no documentation required for this skill. So washing your hands, but I would definitely go back and read that care plan just to make sure that you got everything that was in the care plan, that you got all of your steps.
For the test, do we know the supplies on everything that you taught us. Do we stick with the 4 washcloths for the test?
Yes.
With what we've learned?
Right.
That's in the,
Right, because for the test, it's a mannequin. There's
Mhm.
no actual urine.
Mhm.
There's no feces. So we're washing inside, outside, skin fold, rinsing. Inside, outside, skin fold.
Mhm.
And then we're turning the patient over and washing the backside, up the middle, cheek, up the middle. And then we rinse. Up the middle, cheek, up the middle.
Oh, okay, gotcha.
And then what about drying though?
Drying, you can use the same towel.
Same towel?
Mhm. Think about you when you get out of the shower. You probably only use 1 towel, maybe 2 if you're doing your hair. Okay. Do you dry off your butt before your face? Not usually. No, probably wouldn't want to do that, right? So we just use the same thought processes.
So when you said that when you turn a patient over to their side, the urine comes out
It
a little
can.
more.
Yeah.
Afterwards, would you clean the area?
You don't have to, no. We're just trying, honestly, so there's a part of this I didn't really tell you because it's not relevant to you guys. You need to know how. But when acidic urine hits air, there's a chemical reaction that actually makes it more caustic. The longer it has exposure to air, the more caustic it becomes. So what we're trying to do is wipe off the older urine. The newer urine isn't going to have as big of an impact on the patient.
Okay, so from the front side of washing for a female, for example, you said use soap for all cleaning areas.
Right.
The whole bacterial thing of actually putting soap in that area, would that come into play or does it?
Again, you're going to go by your care plan for the patient that we're working on. There are some patients who are very, very sensitive to soap. In that case, I probably wouldn't be using soap. We would be using water. There's going to be other patients that require a special pH balanced type of soap. So again, those granular details would be up to the care plan. For the test, we're just using soap. Okay, good. All right, Jake, can you play Peri-Care video, please? Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table. And we'll start with
a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about a quarter of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up. Hold it up lengthwise with the absorbent side facing me and roll it all the way to the end. Clean rolls toward me. We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Ms. Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Miss Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The fourth leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the 2 side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The second leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The third leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The fourth leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Miss Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your backside. 1, 2, 3, and we're going to roll up. 1, 2, 3. We'll expose your backside, and the evaluator will hold the mannequin in place for this process. So now I can clean the backside. I'm going to wring the washcloth out. And this time, we're going to soap 4 leaves. So 1, we'll fold that over. 2, fold that over. 3, fold that over. 4, set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over, and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over. Rinse the other buttocks. Fold that leaf over, and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Miss Jones, come on back onto your back, please. Thank you. And then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side. 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Miss Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink. Rinse the basin. Dispose of the rinse water into the sink. Set it down. Disinfect it per facility policy. Use a paper towel to pick it up. Paper towel to dry the inside. Throw that away. Paper towel to dry the outside. Throw that away. And one for the drawer. On the way, we'll pick up the soap. Place it in the basin. Use the paper towel to open the middle drawer. Pick up the lotion and put it in the basin. And then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table. And then remove my gloves. Okay, Ms. Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Any questions? All right, we have one more skill. It takes 2 minutes. Bear with me. Go to page 77 in your book, please. This is range of motion shoulder. We already know how to do range of motion. We just need to know what the care plan tells us. So if you're reading this care plan, it'll tell you to perform the following range of motion exercises to the resident's, I think it's right shoulder. Is that what it says? Left. Okay, to the resident's left shoulder. Flexion, extension, and abduction, adduction. Perform 3 repetitions of the exercise. The patient is unable to help with the exercises. So all we're doing here is left shoulder, patient's left. Flexion, extension is up, down. 3 times. Abduction, adduction is side to side. 3 times. Monitor for any pain.
Make sure you're explaining to the patient what you're doing. Put an opening in front and a closing in the back, and that's the whole skill. It literally takes 2 minutes. I'm going to show you the skill so you can see it all the way through, but it's a 2-minute skill. Okay. Jake, range of motion shoulder, please.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some range of motion exercises on your left shoulder. Is that okay?
Yes.
Let me close your privacy curtain and wash my hands. I'll be right back. Okay, Mr. Jones, the first exercise I'm going to do is bring your arm above your head and back down to the bed like you're asking a question. I'll do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
So we're going to bring your arm all the way up, supporting at both joints. Slowly and smoothly, all the way back to start. Here's one. We're going to do that 2 more times. Up, still okay?
Yes.
Back to the bed, and 1 more. Up, and back to the bed. Okay. The next exercise we're going to do is bring your arm out and back in like you're making a snow angel. Okay?
Okay.
So I'm going to support at 2 joints. We're going to go all the way up and all the way back to start. Feel okay?
Yes.
All the way up and all the way back to start. Still okay?
Yes.
1 more. All the way up and all the way back to start. Good?
Yes, ma'am.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Bed is in the low position. Let me give you your call light. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help.
Thank you.
I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done.
After watching Peri-Care, range of motion looks like a piece of cake. I really should start with the hard ones, right? Because then the easy ones look really easy. All right. Tanny, do I have to raise the bed at all on exam day? You don't have to. You can. If you don't want to bend, raise the bed. But if you raise the bed, what do you have to remember to do? Lower it at the end. Yep.
Well, don't you have to raise it in case you have aftercare?
So head of bed, yes, that's a great distinction. I'm glad you brought that up.
Oh, yeah. Okay.
So head of bed has to be raised for anything, feeding, mouth care, any food or liquid, going in. But the entire bed, raising up the entire bed, bless you, then that's just, for your comfort, not for the patient.
And will they ever trick you when they have it already up, and then when you leave, make sure that they have it down?
They can't.
Okay.
They can't throw curveballs like that because it's uniform testing. Your testing experience has to be exactly the same as hers and his. So otherwise, if they start throwing these little curveballs, it makes your test harder than somebody else's, and that's unfair and can be discriminatory.
But they might do like the obstacle thing during.
Yeah, that's the only thing that that's the only curveball that they might throw at you. But again, it's not in the checklist, so it's not something they're supposed to be doing.
Okay.
Yeah, and Prometric is aware of it and retraining their evaluators. Yeah. Any other questions?
Another question?
are the exam testing when we go video audio? Are they recorded?
Oh, the evaluate. You're talking about the testing experience? No, there's no cameras, no audio recordings. That's why there's 2 evaluators. And actually, I don't want to get too much in the weeds, but that was a possibility about 7 years ago.
Yeah.
And because people were complaining, I did this, but the evaluator didn't check me off, and now I failed, but I know I did it, and there was a lot of back and forth, right? Because it's he said, she said type thing. So Prometric and the Board of Nursing together tried to work out, well, what can we do? Board of Nursing wanted cameras so that they would be able to review. If you said you did something and the evaluator didn't check you off, the Board of Nursing could review it if it's on video. Prometric did not want that at all. So their compromise was 2 evaluators. That's why we have 2. Question, when performing range of motion, you only perform it on one arm. You will do whatever the care plan tells you to. Very important, whatever the care plan instructs you to do. If the care plan says 2 arms, how many are we doing?
2 arms.
2. If the care plan says left arm, what are we doing?
Left arm.
Left arm only. We're going to follow that care plan. Good question. All right, any others? All right, homework for tonight. You have 2 chapters, chapters 8 and 9. 8 is on nutrition. You may have to make a few flashcards on the diets. 9 is on rehabilitation. So helping patients achieve their highest level of function. It's going to talk to you about prosthetics and orthotics and different type of aids that we can use to help with that. Okay. 8 can be a bit tricky. Just kind of keep that in mind. 8 can be a little bit tricky. And then Jake is going to hand out your, no, not that one. Jake is going to hand out your review sheet. Somebody have a question?
Do you have the review sheets from yesterday in hospital?
Yes, they're all right here. And if you guys are ever missing a review sheet, this is yours. You can take off of the display there. So if you're missing any review sheets, just grab the ones that you're missing. All right. Sorry. I tried. You will have practice time on Monday. Okay, you will. I don't get nearly as long-winded on Monday. So, guys, 1 week left.
Thank you.
2 classes. That's it. You are so close to the finish line. I am super proud of all of you. I really am. This is a huge accomplishment. Look how, when we did the review today, I hope you kind of got a sense of how much you've learned in a very short amount of time. And it hopefully wasn't too difficult on you to learn it. Okay.
Another question, Ms. Patty?
Do I use a towel or a dry washcloth when doing partial bed bath to dry the face? Anything we dry, we usually do with a towel. Yeah, but it doesn't matter as long as it's dry. You can use a washcloth if you want to. They don't care. All right. Until next time, I'm going to go ahead and sign off virtual. Thank you so much for hanging in there with all of our technical difficulties. We will see you on Monday for week 4. Next game show will be first Tuesday in October. So mark your calendars. I think it's October 3rd. Till next time, happy caregiving. Bye. All right.